Good morning, everyone. I would like to call to order the Health and Human Services Finance Division. We have an extremely long agenda, as everybody knows. I think we have 25 bills on the agenda this morning, or for the day. We hope to have a lunch break. We'll see how things go. And we hope to not be here till midnight. So we're going to ask for everybody's cooperation. We're going to move through these bills as expeditiously as we can, of course, with respect to everyone's interest in testifying. We are going to ask testifiers to stick to 2 minutes. And many of these bills have been heard already in the Policy Committee, in the Health and Human Services Policy Committee. And we do not want to give them a complete policy hearing if they've had a hearing in the Policy Committee. So this is the Fiscal Committee. We're going to ask the authors to just give us enough so that we know what we're dealing with. Of course, members can ask questions, but please, with an eye to the fact that these bills have been heard, many of them, perhaps not every one, but we'll, as we go through that, we might differentiate. But we're going to focus on the fiscal part of this to the extent that we can and move through these bills pretty quickly. So the first bill on the calendar for today, and we do have a quorum, and we don't have minutes today. We'll get to those later on. So first bill we will take up is House File 725, Representative Fischer. Welcome to the committee, and we have the chair will move that House File 725 be laid over for possible inclusion in the HHS Finance Omnibus Bill. And there is an amendment in the packet. Representative Fischer, is that yours, and do you want to move it right now?
Yes, Madam Chair, that is mine. I'd like to move it right now. It is language that has been worked out between the department, some tweaks that they wanted to make sure that everything flows well.
All right, thank you. So the chair will move the A1 amendment to put the bill in the shape in which the author would like to discuss it. All those in favor, please say aye. Aye. Opposed, no. The motion prevails, and the amendment is adopted. So please go ahead, Representative Fischer.
Thank you, Madam Chair and Committee. House File 725 has broad bipartisan support. I'd like to thank my co-authors, Representative Zerwas, Albrecht has helped, Halverson, Moran. 725 is addressing the reimbursement rate for federally qualified health centers and rural health clinics. These clinics' unique bundled model of care provides an efficient system of primary health care for each patient and is an effective approach in reducing preventable emergency room visits and inpatient hospitalizations. Through an alternative payment methodology, House File 725 modernizes the bundled payment for federal qualified health care programs and transparently recognizes the current bundled model of care that supports comprehensive and integrated access to mental, dental, and behavioral health for patients in our underserved communities. And that is what I have. I do have a testifier here who has some very brief comments.
All right. Thank you, Representative Fischer. Welcome to the committee.
Thank you, Madam Chair. My name is Danny Ackert. I'm the Director of Public Policy at the Minnesota Association of Community Health Centers. We represent Minnesota's 17 federally qualified health centers, or FQHCs, which collectively treat the primary medical, dental, and behavioral health care of 187,000 Minnesotans, or 85,000 of which are on access their care through medical assistance. House File 725, as amended, establishes an alternative payment methodology for FQHCs and rural health clinics. The proposed alternative payment methodology leverages federal law that requires a bundled and encounter-based prospective payment system reimbursement for MA patients at FQHCs. FQHCs are obligated by law to provide comprehensive and integrated primary medical, dental, and behavioral health care services through a bundled one-stop shop model in designated rural and urban health professional shortage areas. These medically underserved areas and their communities are characterized by a severe shortage of available and accessible primary care providers. In 1999, the United States Congress recognized the importance of the bundled one-stop shop service model at FQHCs and mandated a bundled reimbursement for Medicaid patients. The bundled payment model allows FQHCs to easily adapt and change their bundled services and operations to meet the needs not only of each patient, but also of each rural and urban community that they serve. This has allowed FQHCs to treat MA patients at significantly lower costs than other primary care providers, generating both immediate and long-term savings for Minnesota. The current bundled reimbursement was set to reflect the services and operations of FQHCs in 1999. If you have seen one FQHC, you have seen only one FQHC, and none of their services look the same as they did in 1999. So to conclude, House File 725 modernizes the bundled MA payment for 85,000 MA patients treated at FQHCs and transparently recognizes the current bundled model of care that supports, maintains, and increases access to comprehensive and integrated access to medical, dental, and behavioral health care for MA patients in underserved communities across Minnesota. Madam Chair and members, thank you for your time and I urge your support for House File 725. With that, I stand for any questions.
All right, thank you very much. And members, we do have a fiscal note for House File 725. It was emailed to all of us. And it should be at duplicating, and we're just, it's going to be brought up here. And I think it was, like, Mr. Berg, I don't know if you have it there, that you could tell us what's in it before we move on here.
Madam Chair, members, the fiscal note for this bill shows general fund costs of $1,363,000 in fiscal year 21, and then a total of about $11 million of general fund spending in 22-23, but then there's a reduction in spending for the Healthcare Access Fund of about $10 million. So the net general fund spend in the tails is $1.8 million.
Okay, all right. So is there anyone else who wants to testify on House File 725? Are there member questions? Okay, seeing none, House File 725 will be laid over for possible inclusion in the HHS Finance Omnibus Bill. Thank you very much.
Thank you, Madam Chair.
All right, House File 1381, Representative Kunesh-Podein. Representative Kunesh-Podein is going to move that House File 1381 be laid over for possible inclusion in the HHS Finance Omnibus Bill. Welcome, and no amendment, I don't see one, so.
Nope.
Please go ahead.
All right. Thank you, Madam Chair and members. This bill is the Community Solution Fund Grant Program. And the idea for this came from a series of listening sessions conducted by the Children's Defense Fund in Minnesota for well over 5 years. They've kept hearing over and over that communities of color and American Indian communities had ideas and solutions to address their needs, but often did not have those resources that they needed to make sure that our communities are strong and healthy. Sadly, Minnesota has some of the worst disparities tied to child well-being indicators in the nation, and that includes health, education, and infant mortality. Given the disparities in our state, this bill focuses on health, education, and other systems with more intentionality for children of color and American Indian children, and it's looking for ways to leverage the natural strengths of our communities. The Community Solution Fund Program is a strategy by which we can begin to address those disparities in resources to specific communities. It leverages the assets of those communities to address their challenges, and it brings those who are most impacted into the decision-making process. So the very specifics of this bill is based around grants that are awarded to organizations that focus on improving healthy child development outcomes for communities of color and American Indian communities, and it has an emphasis on prenatal to 3rd grade. So our objective here is to address early learning, health and well-being, economic security, safe and stable nurturing relationships and environments. The eligible grantees include organizations, nonprofits, or tribal nations that are either led by or directly work with communities of color and American Indian communities. We will be looking for geographic equity in grant disbursement, ensured by prioritizing grantees located in regions of the state. So this is a statewide grant with high proportions of communities of color or American Indians. The grant will be administered by the Minnesota Department of Health in consultation with Community Solution Advisory Committee, comprised of advocates and leaders from community-rooted institutions. This is a multi-step grant program that will provide for 1 year of planning grants at the local level so that the communities can come together to determine the child well-being outcomes that they would like to address. So this is very locally decided on to address and source those strategies that leverage the community's strength to make the changes. Let me see here. So there's the first year of planning, and after that planning, communities can apply for implementation grants to implement and analyze the solutions sourced during that planning grant. There'll be 10 grants. They are 3-year grants of $150 per year, and then 10 3-year grants of $300,000 per year. So that we are asking for $2.7 million in fiscal year 2020 and $5.2 million in fiscal year 21, and then $5.2 million in the out years. And so that is a little introduction into and about this bill. And I have two testifiers, Barty Wahi, who is the Executive Director of the Children's Defense Fund, and then Brooke LaFoe.
All right, thank you, Representative Kunesh-Podein. And just a reminder, 2 minutes, please, because this bill did get a full hearing in policy.
Yep.
Okay, please, welcome to the committee.
Yes, thank you, Chair Liebling and members of the committee. My name is Barty Wahi, and I'm the Executive Director of the Children's Defense Fund, but I'm also a steering committee member of the Voices and Choices for Children Coalition. Voices and Choices is a coalition that is focused on improving outcomes for children of color and American Indian children 0 to 8. We are focused on the implementation of policies and practices that meaningfully address the disparities that exist in the state of Minnesota and leverage the strengths that exist in communities of color. We support House File 1381 because it is a strategy that addresses the inequities that, as well as amplifies local and culturally relevant solutions and centers the experiences and dignity of those impacted by inequity. 1 in 4 children by 2035 will be a child of color in the state of Minnesota. Addressing the disparities in the state of Minnesota and creating investment strategies that particularly address those disparities will be critical if we want to turn an almost 40-year, if not longer, set of disparities that exist across a variety of child outcomes. We urge you to support House File 1381 because we believe it meaningfully addresses ways to invest in communities that actually center the solutions they think will matter. Thank you.
All right, thank you for your testimony. Welcome to the committee.
Thank you, Madam Chair and members of the committee. My name is Brooke LaFoe, and I am a member of the Turtle Mountain Band of Chippewa, an East St. Paul resident, and an aide at the Montessori American Indian Child Care Center. I support the Community Solutions for Healthy Child Development Grant Program. The Montessori American Indian Child Care Center in East St. Paul is a prime example of a community-centered solution. When there were no early childhood programs existent for American Indian children in the city of St. Paul, but continuously growing disparities, my mother assessed the need for one of these programs to exist. She used her Bush Fellowship to train in the Montessori method, then opened one of the few culturally relevant, internationally recognized Montessoris for American Indian children. The compatibility of the Montessori method with traditional ways of educating American Indian children allow us to provide high-quality care to our children who develop a strong cultural self-esteem with guides and role models who look like them. Community Solutions Grant Program represents more than money. It is also recognition that communities of color, American Indian communities, and geographically dispersed communities have invaluable knowledge and must be active and valued participants within the creation of solutions for themselves. Centering our solutions engages our communities. Supporting our communities is critical because children of color and American Indian children will be the future leaders of our state of Minnesota. Thank you.
All right, well, thank you for your testimony, and congratulations. That sounds fantastic, what your mom was able to accomplish. Is there anyone else who wants to testify on House File 1381? Okay, are there member questions? Representative Moran.
Thank you, Madam Chair. First, I would just like to thank Representative Kunesh-Podein for carrying this bill. It's unbelievable. It's been 5 years since the Coalition Children's Defense Fund has been advocating here. I remember when I first got elected to the House of Representatives, most of the conversation here was about rural urban, right? In the rural community saying, hey, you're leaving us out this process. What about us? And so we have expanded that conversation and said, you know, there's another group of population that's been left out this process. And not only that, you know, we believe that we have the solutions to what will help our community thrive and be better. Long overdue, and glad that there are so many coming together to be a part of this. But I was just wondering, because I do believe that the wisdom of the community is important. And so as we talk about, I was just looking through a draft for a summary of the bill. So is there any specific policies that the coalition is working on that they hope to move through this body?
And,
Any particular policies or that's going to create some different practices?
okay, and thank you, Representative Moran. Representative Kunesh-Podein, and just to remind everyone, we did have a hearing in policy, and
Yeah.
please answer, but we don't want to kind of go through the policy again, but please.
Right. Well, we will be looking for policies that address the well-being of the children, so how we can support those children at a very early age, what sort of programming we can put in place. But it's also really important that the communities that are the grant receivers are the ones that are leading the way on that. And maybe the ED for the Children's Defense Fund would like to say something.
Thank you, Madam Chair. Representative Moran, I think, I think there are a number of policies that Voices and Choices looks at in terms of how does that actually meaningfully address inequities. I think with this particular strategy, what we're really interested in is how we have other place-based initiatives here in the state of Minnesota where we've actually really looked at a population level outcome that a community wants to work on, and then how do you bring resources and folks together. And from that work, how do you sort of develop a policy strategy that then you can leverage at this in this room, in this building? And I think that's what we're hoping to do. Those opportunities for place-based initiatives have been fewer and far between, and we think that this is a way that we could specifically focus on communities of color and American Indian communities with a lens towards equity that could highlight strategies, policies, practices that we could then come back to this body and share.
Thank you.
All right, thank you. And I do want to highlight for members, there are a number of letters of support in your packets. So thank you for providing those. So seeing no other questions, Representative Kunesh-Podein, do you want a final word?
Sure. Again, this has been in the works for 5 years, and as Representative Moran mentioned, there are a lot of people in this room or in this community that have worked really hard and strategically on this bill. I'm very proud to be able to carry it, and I ask for your support.
All right, thank you very much. House File 1381 is laid over for possible inclusion in the HHS Finance Omnibus Bill.
Thank you.
Okay, House File 1898, Representative Hassan. Oh, and in the meantime, members, the fiscal note has been handed out now from House File 725, the FQHC bill that we discussed earlier.
Yeah.
Welcome to the committee, Representative Hassan. The chair will move that House File 1898 be laid over for possible inclusion in the HHS Finance Omnibus Bill. And members, this is a bill that also had a thorough hearing in the Policy Committee. So just a brief orientation to what we're doing here and what the request is would be great. And I don't see a fiscal note in this one, but maybe we'll get to that. So, welcome.
Thank you, Madam Chair. Good morning, Madam Chair and members of the committee. This is my first time in this committee, and I brought some treats.
Those healthy treats?
Thank you.
Madam Chair, those healthy treats that we
Yeah, I hope so.
Today we have House File 1898 relating to health, creating public health awareness campaign on the dangers of skin lightening. Skin lightening creams are used widely in the world, and the dangers of skin lightening creams in the U.S. have, I think, mercury has been removed mostly in the 70s. But any product that's coming from outside of the U.S., which is heavily used in the African communities, Asian communities, as well as some of the Latino communities, contain high levels of mercury, levels that aren't safe for anyone to use, and anyone, especially anybody who is child, in the child rearing age, because that could create, liver damage, kidney damage, skin damage, as well as some cardiovascular issues. I'm not an expert on this, so I have some testifiers with me, and I know in the interest of time will be very brief.
Okay, thank you. Welcome to the committee. Go ahead, please.
Thank you, Madam Chair and members of the committee. My name is Amira Adawi. I'm a public health practitioner and director of Beautywell project. I have been working on this issue for the last 8 years. It's like the representative Hassan said, it's skin lightening practice is highly prevalent here in the U.S. and around the world. Especially in Minnesota, we have a lot of communities of color that practice skin lightening. Women are using multiple products that contain mercury and other toxic chemicals. Today in this bill, we're only talking about mercury, but they also use topical steroids, which over time of usage that can be toxic, and also hydroquinone, which is considered toxic chemical. It was banned in the European countries and Canada, but it's available in the U.S. You can find that from Walgreens and Walmart. And so these women are not getting education right now from local health departments, from their clinics, and just like how education of lead is available in clinics, these education services are not available to these women. Women are using during pregnancies and breastfeeding, and that impacts their health and the child development of their kids. So overall, it's a huge public health issue. It needs to be established as a public health issue in our state. And so this bill will help raise awareness and potentially decrease this practice. And it's so much embedded in the culture that we need to do a lot of investment. So please support this bill, and thank you for your time.
All right, thank you very much for your testimony. And there's another testifier?
Yes, Madam Chair.
Welcome to the committee.
Thank you, Madam Chair, members of the committee. Thank you for this chance to present today. My name is Kathy Raleigh, and I'm an epidemiologist with the Minnesota Department of Health. I work on the Environmental Public Health Tracking and Biomonitoring Program. We work on projects that test chemicals in people in different communities across the state. And the information that we receive from these tests, we use to promote public health actions to reduce these chemical exposures. Today, I'll discuss our recent study that looked at mercury exposure and the use of skin lightening products. The study is called MINFEAT, or Minnesota Family Environmental Exposure Tracking. We measured 3 heavy metals in Twin Cities women and babies. We partnered with clinics in the Twin Cities, and we included Asian, East African, Latina, and white women. All women gave informed consent for us to test their urine and a small amount of their baby's cord blood. So what is the concern with mercury and skin lightening products? We know that it can affect the nervous system, it can damage the kidneys, and cause pain and rashes. We're particularly concerned about any exposure by developing babies, pregnant women, and children because these are sensitive populations. Mercury in these products can't be seen, felt, smelled, or tasted, and it usually is not listed on the label. They are not legal for sale in the U.S., but we know these products are being used. So in a short summary for the findings, we found for the skin lightening products that women in the study who said that they had ever used products, they had more mercury in their urine. And in addition, 9 women had very high levels of mercury in their urine. These women received follow-up to help find and reduce the exposure. This included offering a home visit to check for mercury, and we found that using skin lightening products was the main reason for these elevated cases. The home visits included a handheld mercury analyzer and found that these products were putting mercury into the air that the whole family was breathing. So in one case, just after taking the lid off the jar, it caused air levels to max out the machine, and this cream was stored in the bedroom where children slept. So we can share with you a formal copy of our community report that we're sending out to the participants in the study this week. And we hope these results can help take action to protect women and children. Thank you very much.
All right, well, thank you very much for your testimony. And so, members, the bill does not have a fiscal note because it's a blank appropriation, and I think it's kind of, it's a grant that is scalable, I understand, but I just wanted to ask the author about that or the testifier.
Madam Chair, we don't have a fiscal note ready, and it's a $500,000 a year. It's a grant that goes to Department of Health.
So I guess my question to you, Representative Hassan, is it 500,000 or nothing? Or is there some, is it this something where the more you have, the more you can do, but you could get started with less, Ms. Adaway?
I'll let, Madam Chair, I'll let Amira answer that.
Okay, thank you.
Madam Chair, members, the department sent physical note to the Senate, so I don't know if the department is here to talk about the physical note, but they sent a physical note indicating all of these fees to the Senate. So I don't know if they sent to the House.
Okay, well, okay. Okay, well, thank you. I guess, yeah, all right, maybe, Mr. Berg, could you just speak to that?
Madam Chair, members, I mean, in the nature of this is grants to an outside entity, so, it could be done at a different amount.
Okay, but at least we know the request is 500,000.
Yeah, anything will be helpful. We just want to address this issue.
Okay. All right, is there anyone else who'd like to testify on House File 1898? Do members have questions or comments? All right, I'm not seeing any, and I just want to thank you, Representative Hassan. I think this is a very important issue, and Ms. Adaway bringing it to our attention and working on this, and obviously it's very compelling what you've just presented and what we heard in policy as well. So thank you very much for that. House File 1898 is laid over for possible inclusion in the HHS Omnibus Bill. Thank you.
Thank you, Madam Chair.
And then next bill is also Representative Hassan, and it is House File 1330. Might be out of order, right? Oh, it's just, okay. And members, this one's not in a jacket. If you, like me, had trouble finding it, it's just a one-pager.
Yep.
And thank you. So the chair will move that House File 1330 be laid over for possible inclusion in the HHS Finance Omnibus Bill. And welcome back, Representative Hassan. Please go ahead.
Thank you, Madam Chair. I present House File 1330 relating to human service appropriating money for substance abuse recovery. In my past life, and when I'm not here, I'm a mental health clinician, so I work with people who struggle with mental health and chemical health. And our system of putting people in treatment for 90 days, getting them out, putting them back into the same environment is a failure, in my opinion. I have seen it multiple times where people, spend 90 days in a very expensive treatment like Hazelden, came out, went back to the same treatment, the same environment that we're in, without support, and within matter of couple months or so, went back to using again. So the lack of support and the lack of getting people out of that environment and the same group of people that they used to hang out with that got them in, addicted in the first place is the problem, in my opinion, and this bill addresses that issue. It's a money appropriation to the Commissioner of Human Services to a grant to serve Minnesota under the Minnesota statute of section 124D.37 to provide evidence-based substance abuse recovery services through Minnesota Recovery Corps. I'm going to let with the interest of time, I'm going to let my testifiers explain Minnesota Recovery Corps and what the model that they're doing, how it's different from what exists today. Thank you.
Okay, thank you. Welcome to the committee. Please state your name and go ahead.
Madam Chair, Committee, my name is Peter Nelson. I'm the Director of Research for Serve Minnesota. We're the State Commission for AmeriCorps. And I'm going to talk briefly about Recovery Corps, which is an AmeriCorps program designed to boost the capacity of organizations within our state to meet the needs of people in recovery for a substance use disorder. And in the interest of concision, there are some handouts. On the second page, there's an infographic that talks about the program or gives an overview. Recovery Corps partners with a number of different organizations in the state. Those organizations may work with people in high school through adults, and as well as people who are sort of matriculating through the justice system. The members that serve, we call them recovery navigators, they also come to us through all walks of life. A majority of them are in recovery themselves. All of them are deeply passionate about the issue. All of them participate then in a 5-day training from recovery experts. That training is intended to get them ready to work with people at each of the sites. When they're at the site, what they're doing is data-driven. So what they do is they participate in sort of a goal-setting process with each participant, and they're assessing as well their recovery capital, which covers everything from whether or not they need a job to housing to health care, as well as how they feel about themselves and the degree to which they feel connected to their community. And we're focused on that recovery capital because that's what we want to boost. We know from previous research from our research partners that when people increase their recovery capital, they're increasing the probability of staying in long-term recovery. And there are some very clear economic benefits as well as the obvious benefits to the individual. The last thing that I want to draw attention to, on the last page of the handout, you can see how we measure recovery capital over time. Each time a recovery navigator meets with somebody, they're taking sort of the temperature of their recovery capital and using that to drive their service. We track that over time with the goal of reaching a benchmark of 47 on the way that we measure recovery capital. And the last thing I'll mention is just a little bit about recovery in general is a really wise investment because of the sort of societal benefits and the benefits to the individual. Recovery Corps specifically, we're able to leverage federal funds at a 1-to-1 ratio, which is a good thing. As well as the members, with tuition reimbursement, loan reimbursement, for many of them are interested in a career in recovery, and this helps them pursue that. And at Serve Minnesota, we have a track record of scaling good solutions, and we're excited about the potential in the recovery space. And I'll turn it over to Chris.
Thank you very much. Welcome.
Madam Chairperson, members of the committee, my name is Chris Edrington. I'm the owner and founder of St. Paul Sober Living, past president and board member of the Minnesota Association of Sober Homes, and founding board member of the National Alliance of Recovery Residences. We're on the front lines of this issue. We provide safe and supportive environments for individuals while they're working on their own recovery plans. Serve Minnesota contacted us 2 years ago to start when they started this program, and we have one of their navigators in our location, which when I say our, I mean MASH and St. Paul Sober Living share the same office space. I'd like to paint a picture a little bit, I think, about what recovery, early recovery means, so this could seem more relevant. I think treatment is like triage. Like she mentioned Hazelden, primary treatment is like putting a cast on a broken arm, and really recovery is the physical therapy you do later in the community for the next several years to build recovery capital. It happens in the community. It's about building a life. It's not simply about not drinking and not using. Connecting with others and engaging in the sober community, that is the medicine of recovery. St. Paul, Minnesota, specifically, and our state in general, has been on the front lines of this for years and years, and everybody knows we're a big recovery community. Recovery Corps contributes greatly to this concept by providing a link and establishing that connection, a practical functional program for problem solving, sustaining employment, applying for health care, building a sustainable schedule where your time is spent enhancing your recovery away from threats to sobriety. An organized, fulfilling life is the purpose and the key. The using life looks ridiculous once you can find this. Our navigators from Serve Minnesota receive training through Recovery Corps, gain real skills and rich background in this work. They collect data to be sure our residents are building their recovery capital and help learn the skills they need to be successful. To be of service to others is one of the best ways to maintain a person's recovery. Because of their own experiences with substance use, our Recovery Corps members can connect in a real way with the individuals they serve. They are an excellent resource to help navigate the complicated, sometimes frustrating path to recovery. Trained peer-to-peer support is something that residents can't get from anyone else. Recovery Corps helps build community and, more importantly, confidence and connections so our residents can become gainfully employed and maintain their sobriety. Recovery Corps provides the additional layers of support that are so desperately needed and don't really exist anywhere else. Thank you.
All right, thank you very much for your testimony. And is there anyone else who wants to testify on House File 1330? Okay, this is also a bill that I think was heard in policy. Am I right, Representative Hassan? Or did
No,
this-
this
No,
is the
this did
first
not get heard
hearing
in
for
policy.
this bill,
Okay, this is
yeah.
just a fiscal request. Okay, Representative Acom.
Thank you, Madam Chair, and thank you, Representative Hassan, for bringing this forward. I am a former AmeriCorps volunteer in a different capacity. I was in the Minnesota Conservation Corps, so I'm familiar with the program, and I think it is a wonderful opportunity to take people, I guess you're calling them for this program, recovery navigators, and it's a really cost-effective way to not only provide opportunities to serve the community, but to get experience and network. And so there's a lot of great things I think about AmeriCorps programs. This seems like an intriguing opportunity to expand that into another sector. And so I had a question. I remember when I was in AmeriCorps many years ago, there were terms. And so you would sign up for a term, a year, and you would commit to that. And then at the end of that time, you would get an education award along with all the other benefits that you got with the experience. And so I'm wondering, are there terms that go on throughout the year? Would this be able to be a consistent opportunity to match with a client?
Mr. Nelson? I don't know who wants to answer. Mr. Nelson, maybe?
The match for the tuition reimbursement and the loan reimbursement is still definitely a component for the program. Many of the members in Recovery Corps are folks who are likely looking to apply that in their career path. Like almost all of them are interested in a career in recovery, looking at maybe a chemical dependency counselor or as a certified recovery coach. So many of them are looking at applying that for that purpose after the service of a program year. It's the same, it's likely the same as it was.
Representative Acom.
Thank you, Madam Chair. I guess I meant more, so you serve a year, but usually everybody started at least in the program that I served in, everybody started at we all started in August, I think, and finished up in July. And so does the model that you're using, or does the way it's used today, and this was a long time ago that I was in it, so things could very well have changed and are more flexible depending on the application. So a person's term potentially ending, so they finish and complete their term, is that going to impact their ability to be able to help the clients who might still need more support?
Mr. Nelson.
Thank you for the clarification, Representative Acom. The typical program year still kind of follows that August through July, although folks kind of can come in at different points, and we have a training set up to accommodate that. Yeah. The max number of years to serve as a AmeriCorps member is 4 years, and then folks, if they wanted to stay on working with the organization, they certainly can do that. And we have. I've been told.
Okay, and I have a question as well. Are you? Did you
that was
need
helpful.
more?
Thank you.
All right, and I have a question as well. And on the fiscal piece of this, Mr. Nelson maybe would be the best person. I mean, the request is for $2.5 million over the biennium, and I don't have a good sense of how that money would actually be used.
Sure, Madam Chair. The money will be used to scale the program to reach organizations across the state. We're looking to have partners in the American Indian community, as well as more rural areas. As we know, that the issues of substance use disorder is not something that's confined to the metro area. It's something that affects the state at large. And so the funds would be used to expand the size of the program to reach a broader network of people.
Okay. All right. Seeing no other questions, the chair will lay over House File 1330 for possible inclusion in the HHS Omnibus Bill. Thank you very much.
Thank you, Madam Chair.
Thank you, Representative Hassan. House File 1888, Representative Morrison. The chair will move that House File 1888 be laid over for possible inclusion in the HHS Finance Omnibus Bill. And I do see that there is an amendment in the packet. Another one for the same one. In fact, we have two amendments. One is being handed out. And Representative Morrison, what is your desire as far as the amendments? We have the A3 and the A5.
I would like to move both of them.
Okay, and you need both of them right now to get the bill in the shape in which you'd like to discuss it?
Yes, please, Madam Chair.
Okay, so the chair will move the A3 amendment. All those in favor, please say aye. Aye. All opposed, no. The motion prevails. The A3 amendment is adopted. And the chair will move the A5 amendment. All those in favor, please say aye. Aye. All those opposed, no. The motion prevails. And the A5 is adopted. So, to your bill as amended, Representative Morrison.
Thank you, Madam Chair. Members, this legislation provides short and long-term solutions to meet serious mental health needs of our kids. As included in recommendations from the Children's Intensive Mental Health Service Study developed by Wilder and many contributing experts for the legislature, first, we must maintain what we have. Minnesota's current 370 children's residential treatment beds need state funding to sustain existing services. We also need additional capacity. Today, some providers have 6-month waiting lists to access residential treatment. Consequently, we also have an estimated 100 to 200 youth who are placed out of state at significant cost to county taxpayers and at a disservice to the youth whose treatment is far from connections from family and community. Psychiatric residential treatment facilities, or PRTFs, are approved by CMS for Medicaid payment. With one PRTF established in Duluth and 2 more sites under development, Minnesota providers are deeply engaged in considering new PRTF development and examining if a PRTF model could appropriately serve children they serve in existing service sites. This legislation allows for the development of an additional 150 PRTF beds and allows for conversion of existing facilities to PRTF. The third area of this bill relates to intensive mental health services in the community. Serving children and youth at home is always the first goal, and this legislation expands eligibility to an intensive community-based service that can help youth be served well at home or serve to support transition from residential care to stability when they do return home. I do have 2 testifiers. I'm not sure which one of you wants to go first. But Jason Donahue, Executive Director of Mille Lacs Academy, is here to share his insights with the committee.
All right, welcome to the committee. If you can please be brief.
Thank you, Madam Chair and members. Thank you for allowing me to be able to talk with you about this important ability to support children's intensive mental health services. My name is Jason Donahue. I'm the Executive Director of Mille Lacs Academy, which is located in Onamia, Children's Residential Facility, and I also serve as member of the Executive Board for Aspire Minnesota, which is an association of resources and advocacy for children, youth, and families for mental health and child welfare. 1888 really builds on the capacity, as mentioned, to be able to make sure that children's intensive services can be needed or can be served through continued funding for children's residential facilities such as mine, as well as increase the capacity for PRTF development in a prudent manner and allow for increasing eligibility for community-based responses. Oftentimes, we see children, youth, and families at extremely vulnerable moments. They come to our services after significant difficulty with the impact of their trauma, mental illness, and symptoms. On Wednesday night, I had the pleasure of being able to testify in the Senate subcommittee with a parent that actually, through her testimony, expressed a great deal of love and compassion that her family had to finally decide to press charges against their son as a means of the only way of being able to get their son help. that was desperately needed because these services were not available. As was testified, unfortunately, the state lacks capacity to serve all of our kids. It's saddening to know that many of our youth do not gain access to the services, intensive services, when they need them the most. Our capacity in the state has diminished to 370 residential beds, which was more than double that capacity nearly 10 years ago, and is based on the Wilder study that over 1,000 youth are told annually that no beds exist for them, resulting in between 100 to 200 youth having to be served in out-of-state locations, oftentimes to the detriment of their services, to their family connections, and to county taxpayers. And as we can see, some of those services are not the healthiest in the world, as was recently highlighted in a nightly news report on NBC on Wednesday evening. What we continue to ask for is your support in terms of being able to help us design systems that allow for access of these intensive mental services for children and families in need. We know that serving children in their homes is advantageous for treatment. We know that effective transitions from out-of-home placements for youth to be based back in their communities is advantageous for longer-term success. And we know that integrating families into vital mental health care is advantageous for our communities and the schools. Thank you again for your support on these essential services.
Thank you very much for your testimony. Welcome to the committee.
Thank you. Madam Chair, members of the committee, thank you for this opportunity to be able to come and testify in front of you. My name is Leslie Yunker. I am a supervisor in Dakota County Social Services. I supervise children's mental health and truancy, and I am here today representing MACSA, the Minnesota Association of County Social Service Administrators. We're here today to tell you about our strong support for House File 1888. This file represents a small step in order to be building that community mental health system that is so important to our youth, families, and the agencies that are often the front lines of response for these children and families. This is an incredibly important bill for counties. As one of those first line responders to families who are having challenges and difficulties with their youth, we are often sought out very quickly in that process to be able to support these families and youth and to be able to find them the appropriate services that they are in need of. I remember that I began my career in social services in January of 1980, and one of the first things that I learned on the job was the lack of resources that we could present towards families in order to address these types of issues. I'm now close to the end of my career, and I'm excited to see that there are things like this particular bill that will be available to those families and children that are so desperately in need. We know that counties and the state partner to pay the high costs of care that these children and youth needs. This bill will go to expanding those options for these youth, and most importantly, being able to provide the right treatment for the right youth with the right issue at the right time. We often see ourselves spending dollars to be able to support youth that might not be the service that they need when they need it. Lack of treatment options result in really negative outcomes for youth and families. Our most aggressive and high needs youth are often ending up in emergency departments in the state of Minnesota, waiting for opportunities for them to be able to receive the treatment that they so desperately need. In 2017, over 20,000 youth in this state spent time in emergency departments waiting for appropriate treatment services. These youth are more frequently being placed out of state, and families and social service departments to be able to support those families are having an extremely challenging time in being able to serve those youths that are placed out of state. Thank you very much for this opportunity.
Thank you very much for your testimony. We appreciate it. I think the committee is probably very aware. We all heard from our constituents about the issue that you're describing. So thank you. Is there anyone else in the room who wants to testify on House File 1888? Okay, and I just, before I go to we have a couple members on the list. I just wanted to ask Representative Morrison, I think there's a similar provision in the governor's budget, and do you know if this is the same, or is there what the difference might be?
Madam Chair, I'm not aware that the fiscal note is completed yet, but you're correct, it is in the governor's budget.
Okay, thank you. Oh, and that is true, and thank you for reminding me to let members know there is a pending fiscal note on this bill. Representative Schumacher.
Not my question, but close. Thank you, Madam Chair. I'm looking at the A5 amendment here. And for Representative Morrison, this looks like the House File 1281 bill that we had there. And I seem to recall in Policy Committee that there was an amendment to the 1281 bill, but that this amendment was the original, the introduced language on the bill. Is that, as the omnibus bill gets prepared, should we be rolling this part in, or the amended portions, or what's going on with that? Thanks.
Representative Morrison.
Madam Chair, Representative Schumacher, excellent question. This is a little bit of a last minute thing. I believe I might need to ask for some help. Here she is to save me.
Welcome to the committee.
Thank you, Madam Chair and members. Ginny Palin with the Minnesota Association of Community Mental Health Programs, and thank you, Representative Morrison, for allowing us to make this amendment. Madam Chair and Representative Schumacher, this amendment is only taking the behavioral health home portion of that original bill and amending it onto this vehicle. I think the verbal amendment that you were referring to, or some of the discussion that happened in Policy Committee, pertained to the homeless healthcare respite program that was to be developed. That piece is not included in this amendment. That will be moving forward separately through a different vehicle. So for this amendment, right now, it's just the behavioral health home portion of the bill.
Representative Schumacher.
Very good. That answers it. Thank you, Madam Chair.
Okay, and let me just ask, is there a separate fiscal piece to that? And is there a fiscal note on that, or what's the situation?
Madam Chair, there is a fiscal note that DHS is working on, and I believe that the fiscal note has not been updated to separate out the two components. So the fiscal note will have both of the components on it, but I know that the department is here and would be able to speak to which portions of the fiscal note belong to which component.
All right, we'll ask Mr. Burdick to come and address that. Welcome.
Thank you, Madam Chair. Matt Burdick with the Department of Human Services. To the question, the two components, as I understand it, that are being amended into these two bills, one actually relates to the medical respite, which was amended onto a bill last night. And then this piece, as Ms. Palin described, is being amended onto this bill. The fiscal note request we received was for those two components combined, and that's being processed as we speak. I can obviously not share what the outcome of that is because that's not been complete, but in terms of the component pieces, the medical respite has some administrative resources for DHS to develop this new benefit, and then both the behavioral health home and the medical respite have some medical assistance costs for the state share. The behavioral health home, the rate structure is changing, and then the medical respite is a new Medicaid benefit. So the two moving pieces are the state share of medical assistance and any administrative resources for DHS.
All right, thank you, Mr. Burdick. Representative Kunesh-Podein.
Thank you, Madam Chair. Thank you for bringing this forward, Representative Morrison. My brother and my sister-in-law worked at, and my sister-in-law still works at the Mille Lacs Academy. They've been there for decades. And so we have, learned over the years of the struggles to meet the needs of those children. And they are children, and they're struggling with really serious issues, not of their own making many times. And it's the caregivers that are there. It's the people that are running that program and providing the services that really need the accolades for keeping that going and providing those services in such a tight market with very few greater resources throughout the state. So I would hope that we could address this issue because those youth are the future again. And if we don't help them now, we'll just be dealing with it down the road. So thanks very much.
Thank you.
All right, thank you, Representative Kunesh-Podein. So seeing no other questions, House File 1888 will be laid, as amended, will be laid over for possible inclusion in the HHS Finance Omnibus Bill. Thank you very much for your
Thank you very
testimony.
much, Madam Chair and
Thank you.
members.
Okay, we're going to hear House File 927, which I'm the chief author, but my co-author on the bill is going to present the bill for us. Representative Schumacher. And Representative Schumacher is going to move that House File 927 be laid over for possible inclusion in the HHS Finance Omnibus Bill. And I do, again, want to remind everybody that this bill had a very thorough hearing in the Policy Committee. So I see we have a lot of testifiers on the list, and that's fine. We're going to let everybody testify, but I just do want to, you know, I don't want to kind of just redo what we already did. Maybe we can, you know, I'm hoping to move a little forward, not just rehash everything. Thank you, Representative
Very good,
Schumacher.
Madam Chair.
Please go ahead.
And thank you. And I'll just take a little bit in my opening to kind of explain the issue, and then we can go into the testimony. After passing the value-based reimbursement in 2015, I was approached by the Mayo Clinic to talk about swing beds, and I had very little idea of what a swing bed actually was. But for critical access hospitals throughout the country, if a patient no longer needs acute care but needs a skilled nursing level of care, they can either go to a nursing home to receive that, a skilled nursing facility, or they can be figuratively swung into a skilled level of care at the hospital and stay in the same bed, but they're, again, figuratively swung into that bed and having that level of care and getting that type of reimbursement as long as they choose to stay at that hospital. The federal government limits the amount of days that a patient can be in a swing bed, or the number of days that a hospital can have for swing bed days at 9,125, but the state limits that further. In 2005, we went not from the 9,125, but we're actually at the 2,000 bed day limit here in Minnesota. And so just a little bit of the process. Once patients have chosen to stay at the critical access hospital for their care, and there's been 2,000 bed days, the hospital hits that cap. At that point, 6 more patients are able to choose that hospital to receive their care without having any limit on the bed days that they have. If you're the 7th patient, though, that chooses to have their care at that hospital, you don't get to make the decision. Your family doesn't get to make the decision. The doctor doesn't make the decision. The hospitals don't make the decision. A very good and very professional staff member from the Minnesota Department of Health has to make that decision based on current state law. And so we're taking the choice away from people, and what we're seeing now especially is that as these bed day limits get hit, that people are losing their choice, and they're losing it earlier and earlier in the year. And so the question that I have, and then we'll bring our testimony forward, is why do we limit this choice just because people weren't fortunate enough to need the rehab care, the skilled nursing care earlier in the year? And so with that, to explain a little bit more on why we're making this request and how this is impacting their patient's choice, I have with me today Ms. Johansson from the Mayo Clinic.
Thank you, Representative Schumacher. That was an excellent introduction. It really was. I hope members were listening, because that was about as clear an explanation as I've ever heard in a really short period of time. So thank you for that. Welcome to the committee.
Thank you, Madam Chair and members. My name is Kate Johansson. I'm the Director of State Government Relations for the Mayo Clinic. And I just want to first, of course, thank you for hearing this bill today, particularly to Chair Liebling for her authorship and to Representative Schumacher for his presenting the bill. Mayo is pleased to be here to support House File 927. As mentioned, it did have a very robust hearing in the Policy Committee, and Representative Schumacher has explained the context very well. So I'll try to keep my comments focused to just a few key points and also to some of the financial elements that are most pertinent to this committee. But for us, and frankly, more importantly for our patients, this really just boils down to a single issue, and that is patient choice. We strongly believe that patients should be able to choose where they receive their care. And as noted, in recent years, that choice has been diminished because of the state's low swing bed day cap. When a critical access hospital reaches that annual cap, it no longer serves as an option for patients to choose where they're receiving this care. And consequently, as Representative Schumacher mentioned, a patient who needs care in June might be given different options than a patient who needs care in November. And we don't think those caps and chronologies should be dictating these care options. Rather, it should be families, patients themselves who are deciding what care setting is best for them. And we appreciate that House File 927 will help achieve this. We're also pleased to see that the fiscal notes indicates that there will be no cost to the state, and reiterate some of the key policy arguments that we think are relevant, not only for the state's finances, but for patients and their families and their own finances. I will just note that at least within Mayo's post-acute care program, we have an excellent readmission rate. The state's 30-day readmission rate from this type of facility is usually around 20% if someone is staying in a nursing facility. In the post-acute care program that we run, that number is closer to 8%. So if a patient values that, having this option for them year-round could be a really meaningful element in making the right choice for themselves and their families. I'll also note that on average, people in our program stay 3 to 5 days on average less in the hospital. So that also could be a significant factor in some of those patients and the choices that they're making. I'll also just note that this is an important access issue, particularly in greater Minnesota. We need more beds there, not less. We see an aging population, and frankly, patient acuity is on the rise. And that's something that I think we need to be looking forward to, particularly because this cap has only been raised twice before, and it's taken 10 and almost 15 years, respectively, for us to even get into the process of evaluating this cap and where it should be. We understand that nursing facilities have expressed concerns about increasing this cap. We've been working on this issue with them for 5 years, and certainly will continue to work on it with them this session, but we would appreciate your support, and I'm happy to take any questions.
All right, thank you, Ms. Johansson. I have one member with a question. I have 3 other testifiers, though. Should we go through the testifiers, or did you have a question right now, Representative Munson?
I can ask my question right now, Madam Chair. It's
Okay.
Relevant to the testifier
Representative
here.
Munson.
Thank you, Madam Chair. And I've been meeting with nursing homes in my district, and I represent a very rural district. And we've had a large hospital organization come in and buy up all of the community hospitals and clinics, and they are keeping patients in their hospitals versus going to the nursing homes, which have beds that are available and at much lower cost than the swing beds in the hospitals. So in other words, by keeping patients in the hospitals and swing beds, it's costing patients and taxpayers a lot more money. And they're not doing their due diligence to actually call around and see if there's beds available. And it looks like on the back of this, on page 2 of this bill, that you're crossing out something that, and I don't know the impact of this, but it says in here about having to check if there's nursing homes with available beds. Are you crossing this out so that they no longer have to check, or what is the impact of crossing this out?
Oh,
Ms. Johansson.
Madam Chair and Representative Munson, I'm happy to address some of the points that you've raised. First of all, I just want to myth bust. Mayo and every other provider engages in a robust process that ensures patients are given every care option as frankly regulated by state law and regulation. If I had a social worker here, she would tell you that literally every time we discharge a patient, they sit down with them, they print out a list of every facility within 25 miles, give it to that patient, and let them decide. The only difference is that one option drops off that list once we hit this artificially low cap. We in no way steer patients. We want them to choose the best option for them. And to your point about cost, I will just note that the fiscal note actually indicates there's no cost to the state. And based on the information I said, there actually could be potential savings to patients. So I might quibble with you on, or we would maybe just have to agree to disagree on the potential impact of cost both to the state and patients. With respect to the bill, really this bill was intended to initiate a discussion, given that this has been a 5-year-long negotiation with almost no movement. And we certainly would still adhere to the same discharge processes that we always have. This was more intended to eliminate a process that is very onerous to add just 6 basic swing bed days over that 2,000 bed day cap, because it would not be necessary under the other language in the former part of the bill.
Yeah.
Yep.
Representative Schumacher, did you want to add anything?
No.
Okay. Representative Munson?
I just want to double check with the testifier that nothing in the process is changing. You're just allocating more beds, and this language on the back that's being crossed off that talks about that they must maintain documentation that they've contacted skilled nursing facilities within 25 miles to determine if any skilled nursing facility beds are available, that actually doesn't change the options or require that they do their due diligence for finding a bed at a nursing facility nearby?
Madam Chair and Representative Munson, no, that is in no way the intent. We're happy to work on clarifying that language. If anything, during our discussions with nursing facilities, we've actually offered to increase the level of pre-admission screening and data collection that we do, voluntarily absorbing that cost, and would be happy to work with them to ensure that they're comfortable. We actually updated this statute a couple years ago to include language where families must be involved in the discharge planning process to ensure that those options are kind of being vetted not only by the patient, but but also anyone involved in their care. So we would continue those processes. It's not our intention to change our discharge process.
And Madam Chair, on lines 2.3
Yeah.
and 2.6, it's clear that
Schumacher.
this portion, thank you, Madam Chair, is affecting when the cap has been hit after 2,000 bed days. This bill, of course, goes to the federal cap, so there's no need for this piece to be in there.
Okay, thank you. Thank you. And
Madam Chair, I just want to say, I
Representative
support
Munson.
increasing the number of swing bed days. I just I want to make sure we're not cutting out nursing facilities because I think they offer great care for people, and when there's beds available and it's a lower cost, I hope we can use that. Thank you.
all right, so Representative Haley wants to be recognized. We have the three other testifiers. Some of them are going to probably make or discuss some of these same issues. Representative Haley?
Thank you, Madam Chair, and thank you to the testifiers. Can you, I guess I wanted to ask now because it was in conjunction a little bit with Representative Munson's questions. I hear from constituents that want to stay close to their home. So can you talk to that choice process when beds get full and somebody that lives in Cannon Falls wants to be in Cannon Falls so their family can visit them and et cetera, and they may get moved to another community. Can you speak to that process of patient choice to stay close to home?
Madam Chair and Representative Haley, certainly, as just outlined, we do have a rigorous discharge process. And basically, our limitation is simply providing the list of options that are available. We then contact nursing facilities at the behest of the patient to ask them where they would like to go. We reach out to nursing facilities wherever the patient directs us to go. And then they typically try to respond to us to either accept or reject that patient. So oftentimes, our limit is not based on whether or not we would take that patient. It's based on whether or not the nursing facility would take that patient. But we certainly agree that maximizing choice so that patients have the opportunity to stay closer to home is an objective that's worth pursuing, and frankly, one of the objectives we're trying to pursue with this legislation.
Thank you. And Madam Chair, just to follow up, I guess I don't know if that can be clarified in statute, but if we're making such a large increase in the number, I'd like to see some process that says, there's a prioritization for somebody to stay close to home. And then just a follow-up question, maybe to the author or to the chair. We're currently at 2,000. The Fed is 9,000. That's a huge distance. In your discussions with all the stakeholders, were there other discussions there of 5,000 or 3,000 or 4,000? I mean, we're making a significant change.
Madam Chair and Representative Haley, yes, absolutely. We have actually offered all of the numbers that you just mentioned, and they were rejected.
Yeah. Okay. Thank you.
Thank you for the
Representative
opportunity to ask
Haley.
questions
Okay.
before the other testifiers.
All right, let's move on and bring up the other testifiers. And so we have Aaron Bowie from Care Providers, and then Carrie Thurlow, if you could come down, and Chris Bolt. Who's first? Okay, Ms. Bowie, go ahead. Welcome.
Good morning, Madam Chair, committee members. My name is Erin Bowie. I'm with Care Providers of Minnesota here today as part of the long-term care imperative. I first want to just refute a little bit of what was said earlier. As we have been negotiating, the lowest offer we received from Mayo was a 5,000 day. There was no 3,000 or 4,000 day discussed. Going into the issue, Minnesota has one of the highest number of critical access hospitals in the country. We rank third with 78. Critical access hospitals were set up decades ago to ensure that rural communities have access to hospital care. And to do so, we're given certain benefits such as cost-based reimbursement from Medicare services and the ability to use a certain number of post-acute care beds or swing beds to help stabilize their census. Our historical concerns with swing bed usage in critical access hospitals has been about patient choice and the viability of rural nursing homes. And we need to ensure that the balance of rural access and viability is shared with critical access hospitals and the rural nursing homes. We do know that 22 of the 30 nursing homes that have closed in Minnesota during the past 10 years were in rural communities, which is a critical point to remember as we look at the demographics. We don't want to take any actions that would result in additional closures. We don't know Nursing facilities rely heavily on Medicare payments to maintain a positive bottom line, and these Medicare paid days are the same days used by critical access hospitals in their swing beds. While our Medicare rates are a fraction of the payments critical access hospital receives for their swing bed days, on average, a critical access hospital costs 4 times more for their nursing bed days. And it's correct that this is not a state impact, it's a federal impact. There have been a number of federal studies by the Office of the Inspector General that have suggested that critical access hospitals have their rates reduced to the amount that the skilled nursing facilities receive. We do struggle with census issues, and when census numbers are down, it has far-ranging consequences on employment, wages, and the viability of operations. The proposed increase from 2,000 swing bed days to 9,125 would be financially devastating to our rural nursing facilities. Assuming they eventually maximize their usage of days, critical access hospitals would literally consume the Medicare portion of our operations. A 100-bed day loss. Sure. A 100-day loss from a nursing facility equals about $45,000 in lost revenue. We want to continue to have these conversations. We have had a number of meetings over the years and continue to have meetings now and hope that we can come to a positive resolution before the end of session.
All right, thank you. Welcome to the committee.
Thank you, Madam Chair and members of the committee. My name is Carrie Thurlow, here on behalf of Leading Age Minnesota and the Long-Term Care Imperative. And for the record, we oppose this legislation. We believe that it goes too far. We have made offers to provide some room in the swing bed limit to recognize and understand that swing bed utilization at 3 specific hospitals have increased, but this particular proposal goes too far. To just address a couple of points, the average critical access hospital here in Minnesota uses 800 swing bed days a year. This particular proposal is a statewide policy. So while there are 3 specific hospitals that currently do go over the 2,000 bed day limit, Cannon Falls, New Prague, and Waseca, the majority of of critical access hospitals are nowhere near that limit. There is a process in place, as was alluded to, that when they hit their 2,000 limit and then admit their 6 additional patients after that, there is a process to still exceed that limit if no other nursing home in the area, the community for that resident, can take those patients. Swing bed admissions are expensive and are appropriate for very high levels of care. And so while patient choice is a consideration, we also need to have mechanisms in place to evaluate those patients and making sure that swing beds are, those very expensive swing beds are being used for those appropriate patients throughout the year. And that the limit functions to sort of balance choice as well as controlling cost here. This will potentially financially devastate nursing homes. And if a nursing home in a rural community closes, that takes away a whole lot of choice for a whole lot of other people in those communities as well. And so with that, I'll yield the rest of my time to our third testifier. And thank you as we remain committed to continuing to discuss this issue.
Thank you for your testimony. Welcome to the committee.
Thank you, Madam Chair, members of the committee. Thank you for the opportunity to testify in House File 927. My name is Chris Bolt, and I'm the Vice President of Operations with the Benedictine Health System, providing oversight to our facilities, 5 of which are located in southeast Minnesota. All receive patients from the Mayo Health System. I start by recognizing that Mayo is a valuable partner, and our organizations frequently work together to meet the needs of those seeking high-quality care. The Mayo Senior Services team of a nurse practitioner and a physician round with our patients and participate in a monthly quality council. We also have had board members from the Mayo team serve on our nursing facility boards. While I recognize that Mayo has growing utilization of swing beds, their access for their critical access hospitals, the bill does go too far in increasing the statewide swing bed limit. Increasing the limit to over 9,100 bed days per year could financially cripple Minnesota's care centers by creating an incentive for hospitals to refer patients to high-cost swing beds that could be provided at a lower cost at a facility closer to the patient's home. The heart of the issue is Medicare reimburses critical access hospitals with a far more generous cost-based formula than care facilities for the same level of care. Rural facilities depend on Medicare revenue to remain financially viable as it is a better payer source than Medicaid. Facilities have no price flexibility for the private paying clients due to rate equalization. Medicare revenues help rural facilities keep quality long-term care options available throughout the state. I also believe that increasing the swing bed limit can hinder consumer choice. Steering patients from hospital stay to a swing bed does happen. I have received calls from community members wanting to receive their rehab at our skilled facility in Red Wing, where they live, but were told they needed to go to a swing bed in Cannon Falls or Lake City. While I respect the hospital's need to discharge patients quickly to appropriate settings, most facilities have the capacity and expertise to meet those needs. We can and should effectively partner to address post-acute decisions. By increasing the swing bed limit, you would effectively be taking the brakes off of swing bed utilization rather than leaving a mechanism in place that requires hospitals to evaluate whether a swing bed is necessary. This will undercut important sources of revenue for care centers and ultimately cost taxpayer-funded revenue, or taxpayer-funded healthcare programs more money. I urge you to oppose this legislation. Thank you, Madam Chair and committee members.
All right, thank you. Is there anyone else who wants to testify on House File 927? Representative Hamilton.
Thank you, Madam Chair.
And if the testifiers, I don't know if you have a question for them or if we could let Representative Schumacher come back up to the table.
It's more of a comment.
Okay, please.
All right, thank you, Madam Chair. You know, I guess I'm looking at this a little bit differently and somewhat see a little bit of irony in this debate. I recall not too long ago where we were having the debate whether radiation and oncology centers could be taken from hospitals and private investors could build one of those centers right across the street from our small rural hospital and basically cherry pick the things that were profitable from our hospitals, and when our hospitals were mandated to cover every other service pertaining to health, if you will. And now it appears as if hospitals are wanting to do the exact same thing that many of them were advocating against, meaning we must be able to keep our small rural nursing homes very viable as well. And if the hospitals are able to take away the business that is profitable or helping these rural nursing homes to stay sustainable, I guess I have a little bit of anxiety around that because, you know, I've visited all the nursing homes in the community in which I represent as well, and we must be able to keep these viable for the obvious reasons. So on that thought process, I guess I don't support this current legislation proposal.
Are there other comments or questions from members? Representative Bierman.
Thank you, Madam Chair. I was just wondering on the last testifier's comments about Mayo sending patients to Lake City or Cannon Falls, whether Mayo has a financial interest in either of those two facilities.
Well, I don't know if Ms. Johansson wants to come back up. I think those are Mayo-owned facilities, but I'll let her speak to that. Ms. Johansson.
Madam Chair, Representative Bierman, Mayo has a health system known as the Mayo Clinic Health System. We actually have roughly 60 sites throughout southern Minnesota, including 13 critical access hospitals. And so it's not necessarily a financial interest. I mean, we are dedicated to keeping those hospitals open to serve our rural communities. And I will point out that a series in the Star Tribune by Jeremy Olson shows that rural health faces a lot of the same challenges across the spectrum of care, not just within nursing facilities. I'll also point out that during the policy discussion on this exact bill, the testifier from the Coda Living Center mentioned that this will only impact 3 sites. So it's difficult for me to understand how one extrapolates this policy decision out to being a statewide impact. And also I'll note that our previous testifier said that most swing beds average only 800 days a year, so there wouldn't be a significant threat of this impacting many nursing homes beyond the 3 sites that have been mentioned.
Okay. Representative Grunhagen.
Oh, I would just ditto Representative Hamilton's comments. I have those same types of concerns in my rural district.
Okay. Representative Schumacher, do you want to? Oh, okay. Sorry. Representative Zerwas. Oh, and Haley first. I'm sorry. Well, Haley spoke. Let's let Zerwas speak first, and then I'll go to Representative Haley.
Thank you, Madam Chair, and to Representative Schumacher and Representative Liebling for working on this bill. I know this bill is, it's a really contentious and challenging bill, and so there's certainly a lot of work to put in to a bill like this to find broad agreement. I don't know if you're there yet. I know the executive director of my nursing home facility that serves Elk River and the surrounding areas has great concern about this bill and the potential impact on the transitional care unit within the Guardian Angels nursing home service. And so I don't know if it's the jump from the 2,000 to the 9,000 plus that has everybody kind of up in arms and just kind of scared about the potential impact on nursing homes within the community. And so I would just encourage the author and stakeholders as this bill moves forward, as it's included and brought forward, to continue to meet and to negotiate and see if there is a middle ground. I understand why you landed where you did, being the federal limit, but I'm just wondering if there's an ability to meet somewhere more in the middle, and that would be my recommendation, Madam Chair.
Thank you, Representative Zerwas. Representative Haley.
Thank you, Madam Chair. And Representative Zerwas took some of the words out of my mouth. Because one of the facilities is in my district, I just want to call out, we are so very fortunate to have high-quality care, both in our nursing homes and with our Mayo facilities. And I appreciate the work, Chair Liebling and Representative Schumacher, on this. My efforts here as a legislator and regarding health care and health insurance have always been to kind of search for the golden triangle: quality, access, at a price we can afford. And so I just encourage you to keep the discussions going and to seek a balanced approach. I want to preserve access and quality of care on both the nursing home side and the critical access hospitals in my district. So thanks for your work, and please keep at it for a balanced solution.
All right, and Representative Schumacher, do you want to have the last word? I'm going to give you the last word, and then we'll lay the bill over.
Okay, sure. Thank you, Madam Chair, and thank you for hearing this bill. I do have to say that in different leadership styles, I was never willing to bring this bill forward, and I think that hindered the process of actually getting to a negotiation. And so, Madam Chair, while I would prefer to have the gavel this year and not have you have the gavel, I do appreciate in this one instance that your leadership style is different from mine, and that you're able to bring this forward to actually get something moving, because we haven't seen, I think, honest negotiation or thoughtful over the last several years. And so during this time, I've come with a lot of baggage on this, because I've been dealing with this for several years, trying to get something on the back end before it got brought forward to get some solution, and we haven't been able to get there with that yet. And so I do think it's interesting overall. I'm an introvert, and the reason I know I am because I read books about extroverts to understand them, because I don't want to actually interact with them. But extroverts get energy, I learned, from other people and from being around other people, and from and that there's more extroverts than there are introverts in the world. And I don't really understand why nursing homes don't advertise that as one of their solutions. When you need rehab care, when you slip and fall or you have a knee replaced and you need to have that, there are more extroverts out there. Why aren't they advertising that you can either be at this hospital in your room and have your meals delivered to you, walk up and down the hall and go to rehab once in a while, or you can come to our skilled nursing facility and have community meals and talk with your neighbors and be able to really just gossip and talk about those things. You have activities throughout the day, and we'll even bring you out in the community once in a while so that you're part of that and you're still engaged with people while you're getting that rehab, or you can be at the hospital and have your rehab that way. I don't understand why that isn't being marketed, except for the fact that we have a bill like this in place that says you don't have to market this, you don't have to advertise, you don't have to compete, because there is a law that says that after 2,000 bed days, they have to go to your facility, so you don't have to worry about that. But trying to take that baggage off that I have a little bit on this issue and look at it from a perspective of just first time hearing it today, the thing that would be sticking with me the most is what I would be telling a constituent if they had a serious accident and They went to the Mayo Clinic to receive care for that, kind of speaking from a personal story now. And they received that care. They were able to have either their life saved or their quality of life saved because of the care they received at Mayo. But then they're told that when they need to have that rehab, they can't have that rehab at the same place that they got the care because of a state law that's put in place. And then they would ask me why we have that state law, and I don't know what answer I give them that I think is actually justifiable. This law was set in place in 2005. That'd be the next thing I would think of. And just what has changed since 2005 in population and demographics, in technology, and in healthcare itself. What's changed since 2005, yet this number stays the same. And the 2,000 bed day limit was set because that's what we were able to agree to. Not for any other reason, but we agreed to it because we could agree to it. And if I still wasn't convinced at that point that we needed to have this change, I would look at the testimony today and listen to the Mayo Clinic when they talk about the patients and the quality that they can get there and the choices that the patient should have. And then I'd listen to our skilled nursing facilities and their testimony about the payments and what that impact can have. So I think that kind of sums it up, Madam Chair. And again, I'm sorry you have the gavel and that I don't, but appreciate that you were willing to bring this issue forward and keep the conversation going. So with that, I'll yield.
All right. Thank you very much, Representative Schumacher, for stepping up today and helping on this and co-authoring it with me. And with that, House File 927 is laid over for possible inclusion in the HHS Finance Omnibus Bill. Representative Edelson.
Madam Chair.
Okay. House File 1580, the chair will move that House File 1580 be laid over for possible inclusion in the HHS Finance Omnibus Bill. And let us take a look. There is an amendment.
Yes, Madam Chair, and I would love to move the the A1 amendment.
All right, so the chair will move the A1 amendment to get the bill in the shape in which the author would like to discuss it.
And Madam Chair, these were changes that DHS had suggested that were technical changes.
All right, thank you for that explanation, Representative Edelson. All those in favor of the A1 amendment, please say aye. Aye. All opposed, no. Motion prevails. The amendment is adopted. So please present the bill as amended.
Madam Chair and members, 1580 would put Minnesota in compliance with the federal 21st Century Cures Act. When this was passed, at the federal level, there's a discrepancy in reimbursement from the federal reimbursement. It reimburses at Medicaid or Medicare levels, now not at Medicaid, and so what we're seeing is companies that supply durable medical equipment are going to be seeing losses with their business, and because of that gap. Durable medical equipment, so members understand, are wheelchairs, CPAP equipment, hospital beds. There's a huge list, but durable medical equipment help community members stay in their communities longer without being hospitalized. This is a really important piece of legislation. The money that we will reimburse it will pay back to so much, and these people cannot pick up the cost. They just simply cannot afford it. So I want to move to my first testifier in terms of timing, Sarah Anderson.
Thank you, Madam Chair and members of the committee. I'm happy to testify here before you today and talk about the work we've done historically together to protect access and quality in the Minnesota Medicaid program, and the bill before you today, which will maintain the status quo and protect the quality and the access that we have achieved. As Representative Edelson stated, this bill is here today because of a federal regulation. The competitive bidding program, which was enacted by Medicare and implemented in 2013, has resulted in over 40% loss of businesses across the country. We knew that program was going to be devastating to reimbursement rates, to quality, and to access across the state of Minnesota, and we worked together with the legislature in 2013 and 2014 to delay the impact of the competitive bidding rates, and we succeeded in a long-term solution in 2015 and 2016 in separating Minnesota's Medicaid rates from the Medicare competitive bidding program. It's important to have those rates separated because the populations served by the two programs are different. The Medicare durable medical equipment benefit is available to individuals who are homebound. It is intended to be a short-term benefit. Individuals utilize that in the last time of their end of their life. And the Medicaid population is an integrated community population who need to have access to equipment that will sustain their ability to live their fullest life in the community and in our state's ability to allow them to fulfill the Olmstead promise. This bill will maintain the rates that we have in place today. We'll supplement the reduction in federal matching funds with state funds for the number of HCPCS codes and products that are subject to the competitive bidding rule. And I want to emphasize that this maintains the status quo. It maintains the values that we have affirmed in 2015 and 2016 legislation, and will keep the network and quality that we have in Minnesota. In summary, I want to thank you for our past work together. Thank you for your values of inclusion and community access to the Medicaid program, and ask for your support in this critical legislation to help continue our values going forward. Happy to take any questions if there are any from the committee. Thank you.
Ms. Anderson. Any other testifiers for House File 1580? Seeing none, member discussion. Representative Zerwas.
Thank you, Madam Chair, and thank you, Representative Edelson, for bringing this forward. This is an issue that I've worked on with Sarah and other stakeholders for years, and the reality is that the 21st Century Cures Act and in compliance with the 21st Century Cures Act is unbelievably complicated public policy that involves multiple buckets of different types of categories of durable medical equipment and what codes are mandated to be at the Medicare rate, what codes under the governor's budget proposal the department would like to bring down to that Medicare rate, and then another group that there isn't really a fee schedule or an identified price point, and so the impact on those items gets even more precarious. We've seen a significant provider devastation in Minnesota, especially in greater Minnesota, as companies have gone out of business. And a lot of what goes along with this isn't just buying a wheelchair or buying a walker or something like that. A lot of it is very specialized, specific medical equipment. There's a challenge because if you price everything off Medicare rates, there's no thought or compensation for durable medical equipment specified for pediatric patients and the very specific needs of pediatric patients. And so this is really important. I'm glad that we're continuing to work on this. And hopefully the governor's proposal would be devastating to this group. Many providers would likely go out of business if that were to become law. And so I'm hoping that through negotiation, I've had great conversations with the department and with the commissioner, and I'm hoping that as this moves forward, we'll be able to find some common ground that has Minnesota meet the portion of the 21st Century Cures Act that the state would be mandated to match for that group, and then maybe put off and really study and evaluate potential impacts of those other buckets. Because if we try to do all of this at once, it's going to harm a very vulnerable population in the state of Minnesota, and it would be devastating.
Thank you, Representative. Any other questions? Okay, seeing none, I'll renew Chair Liebling's motion that House File 1580 be laid over for possible inclusion in the HHS Finance Division Bill as amended. Okay, next up for consideration is House File 1522. Okay.
Madam Chair, I hope that members have the A1 amendment.
Okay, it's being passed out right now, so I'll move that House File 1522 be laid over for possible inclusion in the HHS Finance Division Bill. And Chair moves that the A1 amendment be adopted. All in favor, say aye.
Aye.
Opposed? Motion prevails. The amendment is adopted. Representative Edelson would like to present your bill.
Thank you, Madam Chair and members. So the PPECs is what we call them, Prescribed Pediatric Extended Care Centers. Representative Zerwas is a co-author on this and has worked on this for years. I want to thank him for his efforts. In terms of looking at this bill, when it went to policy, first of all, I would just like to note, I haven't received a fiscal note on this, and so members, you don't have one in your packet, right? No, I don't think so. Okay, so there's no fiscal note yet, but we have been working closely with DHS in terms of reimbursement rates. A PPEC center, they have them in about 7 other states. What it is, so we understand what we're talking about, it is for critically complex kids. It is a center that they can go to, and we've really we've worked a lot on this language because before it started at 0 to 21, and we have now changed that language in this A1 to be 0 to kindergarten, and working with the department on that language, but we might change it to 0 to 7 after this. I apologize, just to be very clear on the language. But in terms of this center, right now, kids that are critically complex that have ventilators, and I have pediatric home services here who does a lot of the care for them. But kids that are critically complex right now, so it's a child that qualifies for in-home nursing. They don't have options outside of in-home nursing, and a lot of these kids are staying in hospitals longer than they need to because they can't find in-home nursing. So, I think about if somebody cancels with if I don't have anybody to take care of my kids, I can bring my kids to a daycare, right? How many of you guys have kids? You can bring them to a daycare. These kids don't have this option. And so I feel like it's a state's failure of ours that we haven't created something for these kids to be able to have options, for these families to have options. So that's what this bill addresses. I do have several other amendments, though, that I just want to go through because I've been working with community groups on this. And it is, so if the pages could come up, thank you so much. So the first amendment, because I've been working with advocacy groups on this, I'm just going to keep one. Actually, if you want to pass out all of those. The first provision, the first one that will be passed out.
Okay, Representative Edelson, let's get the amendments in front of us.
Let's get them, yeah, let's get it in front of you.
Does everybody have the A1? Yes. Yeah.
Thank you so much.
Any questions on that one? Yeah, I know. I just want to talk about it. Okay, Representative Edelson, do you want to move all of these amendments?
I would like to move all of these amendments. These are discussions with advocacy groups that we've been working, and we've been listening to them and hearing their voices on how to make this bill better.
Okay, so let's go ahead and make a motion to move the A4 amendment. All those in favor?
And Madam, I'd like to just speak to the amendment really quick.
Let's speak to the amendment first. Go ahead.
Yep, the A4 amendment is providing this. So with the 0 to 5 program, or right before a child enters kindergarten, they can qualify for 0 to 3 services or 3 to 5 services. And so this would direct that the district make arrangements to possibly come to the PPEC. Now, this is very similar to language that's in education that says districts must meet a child at a day treatment center. So we are mimicking that.
Any questions on the A4 amendment? Okay. So I'll make a motion to move the A4 amendment. All those in favor?
Aye.
Opposed? Motion prevails. The A4 amendment is adopted. Next amendment?
Madam Chair, I'd like to move the A3 amendment, and I'll speak to what that is.
Okay, you can speak to it. We don't have it yet, but you can go ahead and explain.
Oh, you, okay. So this is, advocates had expressed some concerns in terms of integration, and this is just, you know, again, this is the first PPEC that we would have here in the state of Minnesota. So it would be exploring ways to have integration, but the reality is it may not be safe medically for kids, but they are going to make every effort to try to do that in a way that's protecting the patients.
Discussion on the A3 amendment. Oh, wait a minute. People have it in front of them. The A1 was adopted and the A4. What is the read?
And Madam Chair, this came up because of Olmsted was brought up, but Olmsted is very different than what we're talking about here. And so I just wanted members to know that we're making a really good effort. These are community centers. We're not talking about institutionalizing kids. So the A3.
I'm going to take a 30-second break. Get her papers ready. Okay, so I'll make a motion to move the A3 amendment. Are there any discussion on the A3 amendment? Everyone have a chance to look at it. Representative Zuros.
Thank you, Madam Chair and members. As I review the A3 amendment and in my conversations with Ms. Munson from ARC, Minnesota, and the author of the bill, I think the A3 amendment is an attempt to address some concerns from community advocates. I think it's a good step forward. I'd be supportive of the A3.
Thank you, Representative. Other discussion on the A3? Okay, all those in favor of adopting the A3 amendment say aye.
Aye.
All those opposed? Motion prevails. A3 is adopted. On to the A2 amendment. Representative Edelson. I'd like to move the A2 amendment. Would you like to discuss it?
Thank you, Madam Chair. Yes. The A2 amendment is during the phase-in period. Again, this was brought up by advocates that respite care would be helpful for these kids. Now, respite care is being able to have drop-in services. That's going to be very complicated to do, but again, it's something that can be explored, and we want to make sure that we're hearing advocates on this, that it can be explored, but staffing is obviously an issue. So we would like to move this A2 amendment.
Discussion. Seeing none, all those in favor of moving the A2 amendment say aye.
Aye.
All those opposed? Motion prevails. A2 amendment is adopted.
And Madam Chair and members, that is all I have. So,
Representative, do you have any other testifiers?
no, but I do have Pediatric Home Services, both Cameo and Susan here, if members have any questions.
Okay. Anybody in the audience would like to testify? Welcome. Please state your name to the committee.
Madam Chair and members, my name is Alicia Munson. I'm the Public Policy Director with the ARC Minnesota, a statewide nonprofit advocacy organization that works to promote and protect the human rights of individuals with intellectual and developmental disabilities. The ARC was founded over 60 years ago by parents who dreamed of a life of opportunity and integration for their children with disabilities. Our counterparts at the Minnesota Disability Law Center have been key partners in advocating for meaningful inclusion as well. We know there's much work to be done in order to fulfill our shared vision of equitable and timely access to services and supports, especially for families of children with medical complexities. That's why we are sincerely grateful to Representative Edelson, the co-authors of House File 1522, and the bill's proponents for shedding light on the challenges and barriers that many families statewide still face. We are also grateful to the bill's proponents for actively engaging community members in discussion about the proposal and for considering stakeholder feedback in developing the amended bill language before you today. However, the ARC Minnesota and the Minnesota Disability Law Center urge the committee to use caution when considering how to prioritize the investment of our medical assistance funding. We encourage committee members to address the shortage of home care nursing, the low LPN and RN wages, and the critical lack of respite services, helping people receive services in their homes and communities rather than direct MA dollars toward congregate settings. Again, we acknowledge the wide array of challenges impacting families of children with medical complexities and look forward to working alongside Representative Edelson and the bill proponents throughout the rest of this legislative session and into the future to identify cost-effective, innovative, individualized, community-based solutions to these problems. Thank you.
Thank you, Ms. Munson. Any other testifiers? Discussion. Representative Zerwas.
Thank you, Madam Chair. And this is an issue that I've worked on for quite a few years, along with pediatric home services and some of the families. And I think one of the challenges is when you talk about when Ms. Munson talks about not wanting to have center-based money, more money going to center-based care and provider shortage. And I think the challenge is that the option isn't for these families whether the children are going to go to kinder care or to a PPEC. These children don't have an option of going to another facility. The reality is in many of these homes, and if you get an opportunity during the interim to visit a home with 24-hour services in your community with a family receiving this type of intensive care for a medically complex and medically fragile child, what you'd see is you have a child, oftentimes because there's so much equipment, in a living room or a family room that's been converted to their bedroom because that's where the ventilator fits that breathes for the child. And all of the other IVs, feeding tube equipment, and all that other equipment. And I think people that have concerns about the bill approach this that they feel uncomfortable that children, medically complex, medically fragile children, are going to all go to a daycare-like setting together, and they look at that as isolating those children. The reality is those children are probably in their homes and in their living rooms 20 hours a day. Now, they might have siblings that they interact with, and they might have a parent that's left their job and is now home full-time. But these aren't kids that would otherwise go to kinder care or the neighborhood daycare or the family daycare. It's children that otherwise won't leave their living room. And parents that otherwise can't work at all. The nursing shortage means that there are days where they can't find nursing coverage to take care of their ventilator-dependent child. And so one parent takes evenings and stays up all night, Mondays, Wednesdays, and Fridays. And the other parent stays up all night, Tuesdays, Thursdays, and Saturdays. And that's their life, and it's their life 365 days. And if they have a 7-year-old, it's been their life for 7 years. And so what this is a part of is saying that those children deserve an opportunity to go to a setting around other children. And despite being in a wheelchair, and despite having a trach, and despite sometimes having a J-tube that they're fed through, or perhaps being nonverbal, they can interact with other children in a safe and fun and inclusive environment. And that's not even talking about the financial impact in this. And in the policy committee, I know that the testimony included a research paper that a physician in Minnesota did that talked about the average weight for a critically complex machine-dependent or ventilator-dependent child that, on average, waits 2 to 3 months in intensive care, longer than medically necessary, because they can't get discharged to go home because there aren't any at-home nurses to take care of them. But if we're talking about a pilot project here, but the idea is if these centers can be used to group several children together in this environment and focus our at-home nursing resources, that's a way of attacking this provider shortage. And it's not the silver bullet, and it's not the only solution, but we've had bills to increase and add a provider rate for at-home nursing to give them a bump for critically complex kids. We've had, as I've advocated for, looking at dynamic scoring of these types of bills because we know that the per day hospital rate for our Medicaid or for our MA payments is significantly higher, and we're paying way more than we need to keep these kids in the hospital, when if we could get them home and taken care of at home, we can do it at 60% the cost. We know that. And so I think there's a financial incentive to look at some of these moves. I think there's a moral incentive to look at some of these moves. And I think there's a family incentive to look at some of these moves. I spent 5.5 months in the ICU instead of being in 9th grade. We didn't have a nurse. I had a Hickman catheter through my chest, and I was on milrinone, a drip to keep my heart beating while I waited for a heart transplant. I spent my entire 9th grade year, now with my friends, now with my family. My dad, luckily, was able to work it out with the city of Elk River, where he came down, he stopped at the police department, picked up his paperwork, came down today. My mom quit her job. She put a cot in my hospital room. She didn't leave the hospital for 5.5 months. Not once, ever. This type of pressure and stress, it can destroy families. I think it made my family unbelievably strong. I mean, we pulled together instead of got ripped apart. But the impact of keeping children in the hospital that don't need to be there. Yes, it's a financial impact. We pay more than we need to, but it's devastating on the children and on those families. And what we're saying is, we're not saying let's change the whole thing and let's change it for everyone, but we're talking about a pilot project with 1 or 2 sites to just say, for the 7 years I've been here, we've tried the same thing. and it hasn't freaking worked. So let's try something new. That's what this bill's about. That's why I'm so grateful that my friend Representative Edelson is carrying the bill, and I wish you the best of luck, and thanks again for doing this work.
Thank you, Representative Zerwas, and thanks for sharing your story with us.
Madam Chair, I was just going to thank Representative Zerwas for all of your contributions and all of your work on this bill in previous years. It's definitely, members, I ask you roll this bill over into the omnibus. This gives families options. These are kids. These are kids like anybody else's kids, but they're not treated the same. They don't have the same options, and I'm asking members to give families options. Other states have done this. I don't think that this takes moral courage. I think that this is the right thing to do. So thank you so much for hopefully your support.
Thank you, Representative. Seeing no further questions, I'll renew my motion that House File 1522 as amended be laid over for possible inclusion in the HHS Finance Division bill. Next up is House File. We're going to do 2385, Representative Howard. I'll move that House File 2385 be laid over for possible inclusion in the HHS Finance Division bill. Okay, Representative Howard, do you have any amendments today?
I don't believe so, Madam
Okay.
Chair.
Then go ahead and present your bill, please.
Thank you, Madam Chair. I have House File 2385 before us, which is an annual drug rescheduling bill. And I understand it takes on a little more significance this year with some of the drugs we're rescheduling, in particular some illicit fentanyl analogs. And with that, I want to turn it over to Dr. Weiberg with the Board of Pharmacy to offer a little more detail about the bill.
Mr. Weiberg.
Madam Chair, members of the committee, I'm Dr. Cody Weiberg. I'm the Executive Director of the Board of Pharmacy. And even though the Board of Pharmacy is not a law enforcement agency, we do have the same authority at the state level that the DEA has at the federal level, which is to engage in rulemaking and to make changes to the state's schedules of controlled substances. If you're not familiar with that, controlled substances are drugs that have some level of abuse potential. Some of them also have FDA approval for therapeutic use, some do not. And about a half a dozen years ago, the legislature actually passed a requirement for the board to issue an annual report to the legislature, which we do every December, detailing any changes we've made in rulemaking. And also for the last couple of years, we've been able to issue a temporary scheduling order without going through the rulemaking process. So we report that to the legislature, and that piece of statute also calls on us to make recommendations to make changes to the schedule. So this is the annual bill. It sometimes comes through the HHS committee, sometimes it just goes through public safety. This year, maybe more than others, there actually is more of an HHS connection, because most years we are just putting things into Schedule 1, which is the highest schedule. These are drugs that have no accepted medical use and have a high abuse potential. But this year, we're making a couple of changes to align the state schedules with federal schedules. So one is to add a version of dronabinol, which is actually synthetic THC, but this is an FDA-approved version of THC. And in addition, we've added a cannabidiol, FDA-approved cannabidiol drug called Epidiolex, which was approved last year for the use of some serious pediatric seizure disorders. So we're proposing to do that. One thing we're also proposing here, which we knew might be controversial and which was amended out of the Senate version, and we wouldn't be opposed to amend it out of here, is to place gabapentin into Schedule 5. Gabapentin is a very commonly used drug. It does act on the same receptor systems in the brain that Valium-like drugs do, although it's not in that chemical category. But we're seeing increasing abuse of the drug in 3 different ways. Rarely it's abused just by itself. More commonly, it is actually used by people who are abusing opioids and heroin because it potentiates the effects, but it also makes taking opioid and heroin much more dangerous and more likely to cause an overdose. And paradoxically almost, it's also being used by people who abuse methamphetamine because it reduces, if you will, some of the side effects that they don't want when they abuse the methamphetamine. There are pockets up in north central Minnesota and down actually by Mankato where the abuse seems to be most prevalent. But that's a very commonly used drug. It does, even though it's not scheduled, it does have to be reported to the Minnesota Prescription Monitoring Program, and it is one of the top reported drugs, so it's widely used. But again, we would not be opposed to an amendment to take that out at some point. And the final thing to talk about is what Representative Howard mentioned. We're also proposing to put a number of drugs and substances into Schedule I, which would make them illegal to sell or possess. And most notably, there are a number of fentanyl analogs, which are incredibly scary drugs. They have no accepted medical uses. They are dozens to hundreds of times more potent than fentanyl itself. And at least one of them reportedly was involved in Prince's death. We also are proposing to put some synthetic benzodiazepines or Valium-like drugs into the schedules. They are very disturbing because some of them are being used as date rape drugs. And finally, there are a number of synthetic cannabinoids, which are far more potent than THC and also very dangerous. So that's the gist of the bill.
Thank you, Dr. Weiberg. We have some questions, but first, are there any other testifiers on this bill? Okay. I have a quick question. Is there a reason why clonazepam was chosen to be put under a Schedule I, but not lorazepam, alprazolam, anything else?
I don't think.
Line 9.24. For clonazepam.
No, that's different. That's not
I read that
clonazepam. Yeah,
My
it's different. No problem.
Representative Cantrell.
Thank you, Chairman, and thank you, Representative Howard and Dr. Weiberg for bringing this bill forward. I really think it is important that we seek to reduce the use and especially the dissemination of these fentanyl analogs in particular. Dr. Weiberg, I just had a couple really quick questions. There are 3 criteria for which a substance is placed in Schedule I. Do you know what those criteria are? I know you know. Can you tell us what the criteria are, please?
Actually, there are, I think, more than 3.
Dr. Weiberg.
I'm sorry, yes, Madam Chair, Representative Cantrell. I think there are actually more than 3. So if the board were to put something into Schedule I, it would have to find that there is no accepted medical use, that the drug can't be, even if there were a medical use, the drug can't be safely used even with medical supervision. The drug has to have a high abuse potential. I guess those are the 3 maybe in just statutes. There's another one, if we're going to do expedited rulemaking, there's actually 2 more. We have to show that the product is available in the state for sale, and we have to show that it has actually caused harm.
Representative Cantrell.
Thank you, Dr. Mann, and thank you, Dr. Weiberg. Well, I agree that the vast majority of the substances included in Schedule I fit those criteria. This is just kind of something that I want to outline for members of the committee is that historically, when the Controlled Substances Act was first passed, there were certain components that weren't passed through the lenses of truly sticking to those criteria that you outlined. For example, opium and cocaine are Schedule II substances under the statute, whereas cannabis is not. So that's something that I think moving forward, we need to make sure that the really nasty substances that Dr. Weiberg described are included and sticking with those criteria, and I think this bill does that. But we also need to make sure that we are always scientific in our approach to how we schedule our controlled substances. So I just wanted to point that out for members of the committee, and I thank you again, Representative Howard and Dr. Weiberg. Thank you, Madam Chair.
Representative Hamilton.
Thank you, Madam Chair. And along that same line of thinking, Dr. Weiberg, are there any benefits that you can see moving medicinal cannabis from a Scheduled 1 to a Scheduled 2?
Madam Chair, Representative.
Dr. Weiberg.
Yeah, Representative Hamilton. So the Board of Pharmacy has actually been petitioned 3 times to remove marijuana from Schedule 1. And we actually went to the legislature after the second time and asked that the law be changed so that the only time that we could take anything out of Schedule 1 is if the federal government did it first. And the reason we did that was if we were to take something out of Schedule 1 before the federal government did it, we would be putting state law into direct conflict with federal law, and we really thought that only the legislature and the governor should be doing that. So from a legal perspective, that's why the board hasn't done it. We've never really discussed what that phrase accepted medical use means from a legal standpoint. If you look at it the way some people do, accepted medical use would be FDA approval, in which case marijuana as a substance itself has not been approved, although both THC and cannabidiol have been approved separately as FDA-approved products. On the other hand, proponents of legalization of marijuana, at least for medical uses, point out that 35 or 36 states, including ours, have created medical marijuana or medical cannabis programs. So from that perspective, if you accept then that what those legislators have done they've effectively, collectively created accepted medical use for marijuana, then marijuana would not fit the criteria that I just mentioned, and because it would have accepted medical use. And controlled substances that have accepted medical uses, but that still have abuse potential, are more appropriately placed in Schedules 2 through 5. And with something like marijuana, the THC-derived FDA-approved products are either in Schedule 2 or 3.
Representative Hamilton.
And Madam Chair, thank you. Dr. Weiberg, if the state did move it from Scheduled 2, would we be able to do more research on the medical benefits at the university level or otherwise?
Dr. Weiberg.
Madam Chair, Representative Hamilton, not necessarily because of the fact that the federal law is still in place. And so it could still potentially be difficult to legally get access to marijuana for that sort of research. In theory, it's available. The federal government licenses some growing facilities to make marijuana available for researchers. And controlled substance researchers have to register with both the DEA and with the Board of Pharmacy. So it could be done. Of course, this legislature and 36 others have, created a medical cannabis or a medical marijuana program despite the federal law. So, the legislature could create, move it out of the schedules and create some sort of law to make research easier in Minnesota that would, again, run afoul of federal law. So again, that's something where we at the board think that elected public officials, not appointed officials and bureaucrats ought to make the decision. Yep.
Representative Hamilton.
Oh, thank you.
Representative Schumacher.
Thank you, Madam Chair. Typically, bills like this are heard in the Public Safety Committee. Has this been heard there, or is this traveling there?
Madam Chair,
Dr.
Representative Schumacher, I'm not sure why it was referred here, I don't know if Chair Mariani has called for the bill to be heard there or not.
Okay, thank you.
Any other questions? Okay, so I will renew my motion that House File 2385 be laid over for possible inclusion in the HHF as Finance Division Bill.
Thank you.
Thank you.
All right, next up is House File 547, Representative Lee. Please present your bill.
Thank you, Madam Chair and committee members, for the opportunity to present House 547, the Taylor Hayden Gun Violence Prevention Act. And Madam Chair, can I have you move the bill, please?
Yes, I will move the House File 547 to be laid for possible inclusion in the HHS Finance Division Bill.
Thank you, Madam Chair. Gun violence impacts every Minnesota community and takes different forms in different parts of the state. Although nearly 2/3 of Minnesotans lives in the Twin Cities, just over half of all gun deaths occur there. I want to share with the committee a couple of gun incidents that have involved young people in my district over the last 2 years. Friday, November 17th, 2017. A class of students were trying on skis outside of Lucy Laney Elementary School when they heard 5 gunshots. This sent students running for coverage and staff frantically making sure everyone is accounted for. Friday, May 18th, 2018. A 12-year-old boy was shot on his way out of the house to go to the store with his mother. Monday, December 10th, 2018. A 14-year-old boy was shot in the face while standing with her sister in front of the store. These incidents make clear that when a community suffers from gun violence, the children do worse in school, people live less healthy lives, and a deeply destructive cycle of violence ensues that harms all in the community. My bill will appropriate $200,000 each year for year 2020 and 2021 to the Department of Human Services to develop a competitive bidding process to award grants to nonprofit organizations with expertise in gun violence prevention, to use the money for gun violence prevention or public awareness and education campaigns. And Madam Chair, with me today is Senator Jeff Hayden to share his story about gun violence prevention.
Thank you, Representative Lee. To our special testifier today, Senator Hayden.
Good. Well, thank you, Madam Chair and members of the committee. It's good to be back. I've spent many a days in this room, in this committee, with a good number of you. So I am happy to be here, and I dressed for the occasion. Wanted to make sure I was appropriate. Once again, my name is Senator Jeff Hayden, and Madam Chair, members of the committee, I am a member of a club that none of you want to be a member of, and that is losing your loved one to gun violence. So on July 23rd, 2016, my sister, Taylor Hayden, a proud graduate of Wayzata High School and Prairie View A&M University, had moved to Atlanta to pursue her career and had just gotten a job with the Enterprise Rent-A-Car Corporation doing corporate leasing. And after 6 months of good work, she was afforded some time off, and her friends decided to go to Atlanta for a girls' weekend. So they rented an Airbnb and went across Atlanta and shopped and had fun and ate, and ultimately ended up at a kind of bar, restaurant, nightclub. And as they were leaving, in the wee hours of the morning, waiting for an Uber, being safe, gun violence erupted in one corner of the parking lot between 2 rival groups. As that happened, they ran through the crowd. One of the gentlemen used my sister as a human shield, and she was shot and killed. So as you can imagine, my father, who lives in Medina, Minnesota, got a knock on the door by the Hennepin County Sheriff folks, and they delivered the message to him and my stepmother and my 2 sisters, Erin and Sydney. And so my father called me, and as you might understand, that was one of the toughest days of our lives. We all know what it is to experience loss, but typically you don't have a feel for experiencing loss to someone who's half your age, your sister, your siblings. I know some of you in this very committee have lost loved ones very close to you. So with that being said, we went down. Nobody was talking. We tried to figure out what was going on. The investigation has run into a stall, and even civilly, the folks that were running the nightclub weren't really responsible, and we're having a tough time tracking them down as well. So we don't want my sister's life to be in vain. So we came up with the idea, and I know that often some of us hear about gun and gun legislation, and it gets to be pretty controversial. Well, this one shouldn't be, because I'm not asking you to make any decisions about how to register a gun or how not, or who should or who shouldn't. What I'm saying to you today, and I want to take a lot of responsibility, is someone made the unfortunate choice to use a gun to settle their differences, and my sister got in the way. And the purpose of this bill is to look at this from a public health perspective, go out in communities that have high incidence of violence, get upstream, preventative, and to get these young people to hopefully make a different decision before they even get their hands on a weapon of any choice, but in this particular sense, a gun. So we think that a public health approach to this is something that hasn't been amplified enough. I know it's something that I've wanted to work on. I think Representative Lee, who represents a part of our community that unfortunately all too often has young people dying of gun violence. I will also say that this is the second time that I had to deal with this issue, because in 1995, my very best friend was killed due to gun violence at a local nightclub here in Minneapolis, under very auspicious circumstances where someone mistook him for somebody else, and he no longer is with us, though his son, who is like a nephew to me, is doing well and is working hard, has a corporate job and a couple of kids, and we enjoy his kids, but he can't. As a matter of fact, my son is now working with and for him. So we are, no matter who we are, where we sit, we have to deal with this issue. And what this appropriation would simply do would to work with, we have the bill as written at DHS. I think the Department of Health is actually probably the more appropriate, and we can work that out. But to get them to go out and look for organizations that work specifically in these communities, most likely with young people, to get them to figure out better ways in which to handle their differences rather than firing a gun. So with that, Madam Chair, members, that is my story, and I look for your support and would willing to answer any question you have.
Thank you, Senator, and sorry for your loss. Are there any other testifiers in the audience today? Representative Noor.
Thank you, Madam Chair. Representative Lee, thank you so much for bringing this bill forward. Senator Hayden, I'm really sorry for your loss. I think this impacts us every single day. And when we see the mothers and the families who are devastated and asking us to come up with a solution, I think this is a public health crisis. And we need to recognize that and be able to come into the communities that are most impacted by gun violence and coming up with good solutions of having preventative measures. And I think this bill addresses the need for us to look gun violence from the public health perspective, and we should do that. So I think this is the first step forward, and I look forward to supporting this legislation. Thank you so much.
Good. Thank you, Representative.
Representative Gruenhagen.
Oh, thank you, Madam Chair. Yeah, thank you, Representative Hayden, for bringing this to light. You have my sincere sympathy for your loss, too. You know I did jail ministry for 13 years, so I've talked to a lot of prisoners who've had similar situations or involved in those types of situations. And it saddens me to hear on the news when a young child is killed in North Minneapolis or in one of our, Minneapolis areas, and it seems like it happens way too often. One of the things I've wanted to look into, though, is to introduce a bill to stop and frisk. I'm sure you're familiar with that law. It allows police in high crime areas, and I have a nice summary of it here, to stop and frisk individuals based upon certain criteria. And it has shown that gun violence drops dramatically when police are empowered.
Representative Gruenhagen, unless you're offering an amendment, we should keep the conversation to the bill.
Okay. Well, and I was simply going to say that I think this is a effective way to reduce gun violence in the high crime areas, and it's proven to be effective. And the U.S. Supreme Court ruled in favor of it based on the information I have back in 1968, I believe. I have a summary I can forward you, but I think there wouldn't be a cost, and it would empower police to address this.
Did you have any comments?
Well, thank you, Madam Chair, Representative Gruenhagen. You know, I think that that's a conversation you guys could have in the public safety committees. There is a lot of data that says that it works. There's certain amount, there's probably just much that says that it doesn't. I could probably go into a long dissertation, I've been around here a long time, about what that looks like and profiling and racial profiling. I just don't think that that's probably the time and place which to do it. I'd love to talk to you more about proven strategies. However, to the bill and to this idea was really an approach that gets to young people prior to them even making the decision to pick up a gun. It's even getting more upstream from that, Representative, to try to get them to not even make that decision to get a gun.
Representative Lee.
Madam Chair and committee, I do want to note that I represent North Minneapolis, and I do want to caution members when we're attributing, you know, a part of a city to having high crimes in your comments when you're making your statement on this bill. Thank you.
Other questions? Representative Baker.
Madam Chair, thank you. And Representative Lee, this is, I think, a great idea. And again, I have talked to the senator, too, about these losses, and they're just terrific. And thanks for continuing to share this horrible story. I think it's something that's got to stay in front of us. I like this idea. It makes too much sense. But help me visualize what this group might look like, or what, does something like this exist now, or is this sort of just a, you know, $200,000 in our budget here is nothing. That's simple, but I'm trying to visualize what this might look like upstream. And so can you give me just a super quick, how would that look? How do we tell kids don't touch these things? Help me with that.
So, Madam Chair, Representative Baker, thank you for that, too. And an example that I could share with you that's similar to what we're trying to do here is in the city of Minneapolis, they have a group called Group Violence Intervention. And they're getting out there to talk to community members who may have perpetuated crime or who are victims of crime, and really working with them to see and understand, you know, what are some of the reasons why you went down the path of using gun violence or for that to commit a crime, and how do we work with you to, you know, remove you from the cycle of, you know, going back into using a certain form of weapons of choice to really do this. And so I think that that's just one example of that too. And in Minneapolis, we also have a group called Mad Dads who are getting out there organizing community members on how could we, and especially young people, how could we resolve our differences without using guns or any other kind of weapon that will inflict harm on community members.
Right. Well, thank you, Madam Chair.
Senator.
Representative Baker. The other thing that I will say is that we want to be sure. So exactly what Representative Lee said, but there was some concern in the committee and in the Senate. This is going to go to direct interaction, right, in programming with those communities. I want to assure members that may think that it might go to anti-gun advocacy groups. That's not what this bill is for, and that's not what we would explicitly make sure that the Department of Health knows that. So I know that there was a concern that I talked to other members in the other body. I want to make sure that people understand that that's not what this is for. It's for groups that Representative Lee talked about that have a relationship with this population that is at risk, that are lives in communities that are trying to kind of wrestle with why they would that they have these issues with each other, and what are the kind of things that they need to do to de-escalate, to redirect. And then we also hope that from there that they can develop a relationship that then we can refer them to organizations, get them back in school, and if they're kind of past that age, get them into a lot of the programs that we fund here so that they can move on with their life and not spend the rest of their life in the criminal justice system. Madam Chair, good to see you. That's my
Hello,
old
Senator.
seatmate, Representative Liebling. I would like to say that my middle sister, Erin, has come. This is Taylor's sister, and she was trying to navigate our community. I don't know if we have just a few minutes, Madam Chair, just to hear from her. This is Erin Hayden.
All right, very good. Welcome.
Hi, who said that?
Right here.
Hi.
Yeah, hi.
Hi, thank you for having me today. It's
And
really
just,
good to
just
be
say
here.
your name, please.
I'm Erin Hayden. I'm Taylor's little sister.
Okay.
And I kind of wrote down what I wanted to say so I can keep my thoughts concise. So, like I said, I'm Taylor's little sister. In January, I turned 25 years old. And although it was an amazing day and I was surrounded by my family and friends, I couldn't help but to note that I was now the age Taylor was when she was killed. I think about my experiences so far as a 25-year-old and wonder if my sister went through similar things. The thought of me in this moment being a young, successful, self-employed woman with amazing friends and family, a woman who enjoys the movies, church, sporting events, traveling, and then one day not coming home because I have been shot and killed is a fear that I live with daily. And maybe it's not just me that I fear for. Maybe it's my mom who works at a school with 4,000 students not coming home, my dad who works in the community not coming home, my little sister who just turned 21 and is a student at a university not coming home because they had been shot and killed doing their everyday routine. There isn't a place that has not been touched by gun violence anymore, no matter how sacred. Taylor would have turned 28 last month. I'm saddened and I'm disappointed because this didn't have to happen. Taylor was a healthy, smart, successful woman that was coming into her own. I'm saddened because I have to speak about my sister in the past tense, because I can only remember her through pictures and videos, because we will never make new memories, and because my future kids will never know their aunt. If time could be reversed and the person who killed Taylor had someone step in when they were young to show them that they didn't have to solve problems with violence, my sister would probably be here today. But we cannot reverse what has been done. The only thing my family wants to do is help ensure other people never have to feel the pain we have. Through this act, I believe we can change the mindsets of our young ones, that you don't have the right to take someone else's life and you should never want to. Through this act, I believe that other families will not have to get the phone call we did at 9 a.m. on July 23rd, 2016. Thank you.
Thank you very much for your testimony. We asked if anyone else wanted to testify. Okay, I do have, there's a question, but I want to first ask if anyone else in the room wants to testify on House File 547. And there is someone who would like to testify. Please come down. Welcome to the committee. If you would just give us your name and then go ahead.
Hi, my name is Abdul-Razak Bihi. I'm a Somali. I work with the Somali community, and I live in Cedar Riverside. Our legislator Mahmoud Noor is my neighbor, and I here to testify. I'm also here to introduce a young, inspiring young lady who's in college to visit Mr. Noor because she loves politics and to get involved. But I'm also here to testify about gun violence. I have never seen anyone being shot before 4 years ago. And I was on Cedar Avenue getting Ethiopian food when I heard shots and I come out and I saw a young person dead. And that's now getting more in my community. A couple Fridays ago, 6 different, geographically different areas were the scenes of Somali American young people shooting each other. Guns are becoming cheaper and cheaper and accessible. I'm not here to say people who enjoy to hunt or have guns, to offend them, no. But we are really scared about the growing threat of guns in young people, and we would love you to support to restrain in any measures to. I live in Cedar Riverside, and I lived there 22 years, and I want to continue living there. I don't want to run away from my neighborhood because of gun violence. We have so many young people. I have 2 beautiful daughters and a wife, and I want to stay, and I don't want to flee again. I fled a long time ago from Somalia. Thank you.
Thank you very much for your testimony. And if you would please make sure the page gets your name and I assume we have the page. Yeah. Oh, thank you. Okay. Representative Munson.
Thank you, Madam Chair. I didn't know I'd be the first to speak. Thank you, Senator Hayden, for bringing Taylor's story forward. Again, it's a very heartbreaking story. I'm just really concerned about making gun violence an issue of public health. I think that really a bill like this that appropriates money for a program such as the one you're seeking should really come out of public safety, because that's an appropriate direction of where this bill should go. It's like trying to prevent texting while driving by declaring that a public health crisis, and then going from having the Department of Health get involved with administering rules and regulations around driving. That's really should go through transportation or public safety. And so for that reason, I oppose this bill, but I hope you can do more to prevent violence. Thank you.
Senator Hayden, you look like you want to respond to that.
Yeah, well, good.
Please.
Well, thank you, Madam Chair, Representative Munson. I think if we continue to look at this in a very traditional way, we're going to get very traditional outcomes. So what we've tried to do is to look at this from a much different perspective, and I believe that the Department of Health and the work that they're doing, and even Human Service, having these kind of conversations and interventions of the behavior. So what I will say, and I've served on these committees a long time, I serve as the Democratic lead in the Senate on this issue on behavior. And we spend a lot of time and efforts helping people. You guys have spent a lot of time on the opioid crisis. And one of the things that we learned, unlike in the 80s when we had a criminal justice response to drugs, now we've learned and we have a medical, a human service, a health response to opioids to get upstream from this. So I would just respectfully challenge us to think about this in slightly different terms as we've evolved our thinking in terms of how we deal with behavioral health, substance use disorders, and drugs and alcohol. Often what is happening is the behavior is causing people to do this.
All right, thank you. Representative Mann.
Thank you, Madam Chair. And I would also like to add that no one is trying to make this a public health issue. It already is a public health issue. The number of people who are dying from gun violence makes it a public health issue. And so not only is it appropriate to treat it as a public health issue, it's demanded at this point in time.
Thank you, Representative Mann. Representative Cantrell.
Thank you, Madam Chair, and thank you, Representative Lee, and thank you, Senator Hayden. I'm so sorry for your loss. To Dr. Mann's point, or Dr. Representative Mann's point, until 19, they're both important titles. Until 1996, the CDC did study gun-related violence and fatalities as public health matters. That was until the Dickey Amendment, which zeroed out the portion of federal funding for the CDC that would have gone towards gun violence studies of as it relates to public health. And I will say that the American Medical Association has been calling for us to again study gun violence and gun-related fatalities as public health issues because, as Dr. Mann said, they are public health issues. So I just wanted to add that studying this issue as a public health crisis is not unprecedented. So I thank you again, Representative Lee.
All right, thank you, Representative Cantrell. Representative Moran.
Thank you, Madam Chair. I just wanted to say to Senator Hayden and Little Hayden that my condolences goes out to you and your family, and that, here in the legislature, we have to go beyond our traditional thinking and how we respond to issues that are impacting communities, whether that's urban, rural, whether it is from a diversity lens. There's many ways of tackling an issue and a problem. And for what this bill does is an educational component. It is really about the health and the well-being of individuals and families and community, and what we can do to get different results. You know, we talk a lot in this committee about Results Plus, best practices, evidence-based practice. We've been talking a lot about trauma-informed policies. We've been talking a lot about ACEs. And all of this has to do with how we find ourselves in this situation where we are inundated with these type of results in gun violence. So my hope is that we can look beyond our traditional lens, listen and learn from other people, and find a way that we can make sure that we have communities across the state that feel safe, but also have other options to help them deal with the stress and the trauma and things that are impacting their lives every single day.
All right, thank you, Representative Moran. I have had a suggestion that we may need to do an oral amendment to the bill. Representative Lee, apparently the Senate version is the Commissioner of Health instead of the Commissioner of Human Services. Actually, this kind of goes to our conversation. But did you want to move the oral amendment?
Yes, please, Madam Chair. I'd like to move the oral amendment to change it from the Commissioner of Human Services to Commissioner of Health, please.
Okay, so since you're not on the committee, the chair will move on line 1.8 of the bill to change, to delete the words human services and insert the word health. And then on line 1.14 to delete the words human services and insert the word health. So we're changing the agency that would be managing this, this grant. And is there any discussion to that change? And I understand that the agencies are in agreement with this. Senator Hayden.
Madam Chair, yes, in the Senate, that it was the suggestion from those two departments, and they, the Department of Health testified in the Senate that that was okay.
All right, so that is the motion. Does everyone understand the motion? Okay, all those in favor of the oral amendment, please say aye.
Aye.
Opposed, no. Motion prevails, and the amendment is adopted. Representative Munson.
Thank you, Madam Chair. We're a fiscal committee, so we kind of have to take a lot of the emotion out of what we do here and talk a lot about the financial part of this bills. And what I noticed in this bill is that it's awarding grants to nonprofit organizations, but it doesn't restrict those organizations to be ones that are based in Minnesota or doing business in Minnesota or focusing their efforts here in Minnesota. And with the chair's permission, I'd like to add language to the bill to actually restrict it to be giving to organizations that do business in Minnesota, and that it just not be thrown into a national lobbying organization that might not even use these funds in our community. If the bill's author would be accepting of an amendment like that.
Well, Representative Lee?
Madam Chair, and, in the bill, we have said that, this is for the Commissioner of Health to develop a competitive bidding process, and I would believe that our commissioner will take that into consideration and establish that when they're going through this process, if the chair do include this in the finance bill.
Representative Schultz.
Thank you, Madam Chair. And I believe that language would not be necessary because the agency, when they put together the bidding process, that it's embedded in their rules that it's for Minnesota organizations only.
And I'd like to ask staff, is it, let's see, is it Ms. Clarkfist? Are you the health department person? Can you speak to that? Whether we would need special language to make sure that the grants are distributed in Minnesota, or is that something that's embedded in the process already?
Madam Chair and members, I think maybe the health department could speak to that. I'm not aware of anything in the grant requirements developed by the Department of Administration that specifically requires that.
Okay, if we could get someone to come down, please. Welcome to the committee. If you just tell us your name and go ahead.
Yes, Madam Chair. Mark Kindy with the Minnesota Department of Health. I head up the Injury and Violence Prevention section. And while there's not explicit language right now in the rules that govern grant making through the agency, so we would certainly, we would welcome that if you wanted to make it direct. The practice has been that for grant making along these lines, our practice in the request for proposal would be to ask for and call for Minnesota-based organizations serving Minnesotans.
Okay. So Representative Munson, if you want to make an amendment, you don't need the chair's permission to make an amendment. I'm not saying I would support it. At this point, I think the testimony is that it's not necessary. If you wanted to make an amendment, you certainly, if you want to offer one, you certainly can, and then we can discuss, I don't know what your amendment would be exactly, but, you can certainly try if you like. I'm not going to stop you from doing that.
Madam Chair, one of the concerns I have is that, and maybe the testifier from the Department of Health could answer this, but do you give, would a 501, I believe it's a C4 organization or a lobbying organization, be allowed to receive these funds? Or, the way I see it is a 501c3 or a charitable organization that's out doing outreach and education of the people might be a better use of this money versus just throwing it in a pile of some national lobbying or, anti-gun lobbying organization that just likes to donate money to campaigns in order to buy their way into preventing guns. That's not the solution here. And I think most of the people that are committing violence on the streets are people that shouldn't be having guns in the first place under our current laws. And so I just see this as a fruitless effort if we're going to give it to a lobbying firm. And I'd love to see an amendment to this that would prevent us from granting money to a lobbyist organization.
Mr. Kindry, right?
Kindy.
Kindy.
Yeah, K-I-N-D-E. Madam Chair, Representative, it would be highly unusual. Epidemiologists try not to use the word never, but it'd be highly unusual for the health department to make that kind of award. The very organizations that Representative Herr mentioned are those exactly who we'd presented in the testimony to the other body, and these are our partners in doing this kind of work. So, thank you.
Yeah, thank you, Mr. Kindy. So,
Madam Chair, I'll withdraw the idea of making an amendment. It sounds like they're not going to be handing it over to lobbyist organizations, although it might be unusual. This bill is unusual, making gun violence a public health issue. So over that, I'm deeply concerned, too. Thank you.
okay, thank you, Representative Munson. And let me just ask Mr. Kindy while you're there, is there a way, without us putting a report in this bill, is there a way that legislators will hear what comes of the grant so that we will know that, who it went to and what work was done? Mr. Kindy?
Madam Chair, absolutely. We report in a number of venues on deaths by suicide already. That's a legislative report, and on some other public health reports through our commissioner. And we're regularly making these available on the health department's website. And yeah, absolutely.
Right. So, Mr. Kindy, as I'm understanding you, so if this bill becomes law and these grants are awarded, we would be able to, and the public would be able to go and see to whom they were awarded. Is that what you're saying? It'd be very transparent.
Madam Chair, that's exactly right.
Okay, very good. Thank you very much. Any further discussion? Representative Hamilton.
Thank you, Madam Chair, and I'd like to thank the authors and Senator Hayden as well. I'm a strong Second Amendment supporter, strong supporter of the Second Amendment, and the district that I serve is also. And you think about the discussion around whether you're pro-gun or anti-gun, it's all surrounded by gun violence and innocent people such as your sister that have lost their lives. And this is one of the most thoughtful and productive bills that have come before this legislature to address that I believe could truly bring people together in the honor of your sister. So I support this legislation. Thank you. Thank you.
Thank you very much, Representative Hamilton, and thank you, Representative Lee. Thank you, Senator Hayden, and was it Aaron? Aaron, thank you very much for your very moving testimony. We appreciate it. House File 547 is laid over for possible inclusion in the HHS. Oh, I'm sorry, Representative Lee, you want a final word, please?
Yes, please, Madam Chair. And just want to say thank you to the chair and the committee members for allowing us to have this discussion. And, you know, we really do have to look at how gun violence impact the health of our community. And I just want to close it off by reading a quote from the principal from Lucy Lane Elementary School that have experienced that shooting in my district. And I quote, "No principal training can prep you for their shooting. And knowing you have kids out there and running through the school to them and touching them as they come in to make sure they're in one piece and not bleeding and pushing your kids away and calling their parents with a shaky voice message. We don't live in Afghanistan. Members, please, we cannot let gun violence become a new normal, and we must stand together to address this. Thank you."
Thank you very much, Representative Lee. Thank you to everybody. So the bill is laid over for possible inclusion in the HHS Finance Omnibus Bill.
Thank you, Madam Chair, members.
Thank you. All right, we're going to, so that we are soon going to take a break for lunch, but we think maybe we can get in one very quick bill before we do, and that would be House File 1254, Representative Considine. And members, it's the very last bill in your packet. So, welcome to the committee. Representative Considine, the chair will move that House File 1254 be laid over for possible inclusion in the HHS Finance Omnibus Bill. And I know there is a fiscal note for the bill, and we don't have it in the packet.
The pages have copies of it,
Okay.
and we'll pass it out to all the members.
Excellent. Thank you, Representative Considine. So the bill is before us. Please go ahead and please be brief because you're standing between people and lunch.
Oh, my goodness. And I want to thank the chair for her wisdom and compassion in getting this bill before you. Would like to correct one thing for the record. In HHS policy, Representative Albright said this is a great, amazing bill. The bill's so-so. It is the actual program that it represents that it's amazing. So everybody, frankly, loves this bill. The sheriffs, the county, NAMI, it is amazing. It is diverting mentally ill people before they are placed in jail. They are putting a social worker right in the booking room, getting the people the help they so desperately need in proper placement. I'm incredibly proud of Blue Earth County for having done this, but the chair was very specific that I had 2 minutes, so I'm going to turn it over to my testifier, and then hopefully just some very short questions. Thank you.
All right. Thank you, Representative Considine. Welcome to the committee.
Thank you. Good morning, Madam Chair and committee members. My name is Angela Youngerberg. I'm the Director of Business Operations for Blue Earth County Human Services. I'm here this morning testifying on behalf of Blue Earth County and MICA, the Minnesota Intercounty Association. Representative Considine outlined the Yellow Line project. I won't go into detail on that, although we started the planning in 2015 and became operational 24 hours a day in 2017. We've helped many individuals by providing screening and community-based care coordination for individuals that are referred by law enforcement that could benefit from mental or chemical health services that could also prevent unnecessary incarceration. Understanding that this is a finance committee, I'm really focusing in on the numbers, and I also understand that you would want to know what the local impact is. In Blue Earth County, we have saved annually, and this has been trending we have reduced state hospital costs annually over $200,000, and we've reduced our detox costs by $100,000 annually. Likewise, we've seen a slight increase in chemical dependency treatment costs, but that's because we're sending more people to treatment versus incarceration, and so that is a good increase in cost. the reinvestment of 24/7 access locally and for other counties that are looking at expanding this philosophy statewide. It's necessary that we do some technical cleanups on language that's currently in statute. 2017 legislation that was passed directed DHS to seek a state plan amendment to allow for community-based care coordination. There are three things that this bill does. It allows tribal nations to engage in providing this service. It adds a professional type of licensed alcohol and drug counselor to the eligible providers. And it also aligns the non-federal share to the state, which cleanly addresses the concerns that were addressed by CMS when we sought this amendment. And so those are the highlights of this bill, and the ongoing sustainability and replication by other counties and tribes will depend on these changes as a funding source. So I sincerely thank you for your time and support this morning.
All right, thank you very much for your testimony. Is there anyone else in the room who wants to testify on House File 1254? Okay, I'm not seeing anybody. Are there any member questions or comments? All right, not seeing any of those either. So Representative Considine kept his promise. So House File 1254 is laid over for possible inclusion in the HHS Finance Omnibus Bill. Thank you very much.
Thank you, Madam Chair. And again, this is nothing but win-win, and it does the right thing.
All right, thank you. All right, members, we will, I would ask you to please put your bills that we have not heard back in your folders. We are going to, we'll still be in this room, and everything can be left. I mean, I don't know if the room will be locked, though. So the room will be locked. We will recess until 1 o'clock, when we will take up the rest of the agenda. And so with that, thank you, everyone. We are in recess.